This is the Pearl index or the failure rate of the common methods. So if you see the female and the male sterilization, that female and the male sterilization which is supposed to be permanent method of sterilization, that should be the best effectiveness. So female methods are 0.5% failure chance and the male methods are even better, 0.1% failure chance percent actually. But if you look at the top one, the implants are 0.05%. So actually, if you look at the implants, the progesterone implants, like all those Novels, the Jadel, or the implants with the Jadel implant which is used, or the Implanon implant which is used, all these implants are even better effective, and the levonorgestrel IUCDs, these are also very good. But the progesterone implants have the best effectiveness. That's why we say, don't say female and male sterilization are the best. Even better are the implants. The hormonal implants are even better. But why are we not giving that to everybody who want contraception? Because if you give hormonal implants, they will give contraception, but the endometrial lining will get atrophied because of the continuous amount of progesterones which are acting on the lining, and that will make the woman amenorrheic. She will not have periods. Most of these patients stop having periods, or they have a lot of spotting. So they are not very happy with this method. Yes, a woman who's getting regular periods and she's having a contraception, those methods are the ones which are the methods of choice. That's why we keep asking this question, that what is the best method for this condition. I'll try to do that also today itself, but let's see. So we are talking about the implants, they are the best, and the female sterilization and the male sterilization 0.5% and 0.1% respectively. And COCP is another hotshot topic, 0.3 to 8% can be the failure, but generally we don't say 8%, that is a little exaggeration, that's the range. But generally we say it's around 0.3 to 0.7% is the failure rate with the combined pills, okay? And what is very interesting to see is the condoms. Condom starts itself from 2% failures to 18% failure. So if a person is following all the instructions that condom should be applied only on a fully erect penis, and then once the person has a fully erect penis, after applying the condom, the reservoir should not be pushed over the glands, and the reservoir should not be checked for patency because it may cause micro tears. And then in a fully erect penis, he should have intercourse with his partner, and when ejaculation happens, then immediately at the time of ejaculation, after the ejaculation, he should hold the condom at the base of the penis and withdraw, and then discard the condom after rolling it out and take a wash before coming back to his partner. This kind of instructions when sex is happening, because sex happens generally in a hurry, it's a moment of passion, all of us understand that, isn't it? So people don't follow all the instructions so well. So when they don't follow the instructions so well, there can be failures in condoms, and a lot of people wear the condom only when they are about to ejaculate. What is the meaning of that? That they're having penetrative intercourse, and when the man feels that he's about to ejaculate, he withdraws and then wears a condom, and then he ejaculates into the condom when he's having intercourse. So what happens with that? The pre-ejaculate from the penis has already gone into the partner. So that pre-ejaculate will take the sperms, and that's why condoms fail so much. So nobody follows the instructions so well. That's why the failure of condoms can be 18%, up to 18%. In fact, some books will say 14 to 20% is the failure rate of condoms. So before I go into detail in the chapter of contraception, I don't want you to say condoms for any situation. Guys, listen to me properly. I am trying to tell you very important fact here today. Ideal contraception in this situation, that situation, I'll never say condoms. Look, condoms is that one answer which you people have a tendency of answering. If I ask you what is the best method of contraception for a woman who is following up after, let's say, vesicular mole evacuation, you'll think, and then you'll say SIR barriers. Then I'll ask you about diabetes in a woman, SIR barriers. Then I'll ask you about, let's say, epilepsy, SIR barriers. So ultimately, you're going to say barriers for everything. Then why am I teaching all the other methods? Let me just tell you contraception is equal to condom and just close the chapter. Why am I giving you a cafeteria choice? We keep saying there's a cafeteria choice of contraception. Why am I giving you that cafeteria choice? Because condoms are not the best. Very important fact, that do not think of condoms as the best or the first management anywhere in contraception. Think of condoms to prevent infections only. That is the best use of condoms. Yes, it prevents pregnancies. Yes, we know that. But we always know that the condoms are the most commonly used contraception in the whole world. Condoms are sold in millions. Yes, because sex is happening across the continents. The sexual habits have changed so much. Even in our country, people are having casual sex much more than before. So, for that kind of sex, thank God there are condoms to prevent infections, but not to prevent pregnancies. Pregnancies prevention is not so guaranteed with the condoms. So, yes, condoms are the favorite contraception of the world. I agree with you. That much I can give you. But for the ideal situations, never say condoms first. Think of all the choices before you say condoms. So let me tell you now itself, the only place where I'm going to teach you condoms are the best are for prevention of HIV, STDs, all right, all those conditions. Genital infection prevention, I will be telling you condoms, okay? So that's what is a very important fact I've told you in the beginning of the class, right? So let me tell you something else. What is the medical eligibility criteria by WHO? So the medical eligibility criteria means that suppose I'm telling a woman is newly married and she wants to not have children for the next 2 years. Newly married couple, we say OCPs, combined oral contraceptive pills, are the best method of contraception. Correct. You know that answer already. So, young woman, let's say 25, no hypertension, diabetes, no cardiovascular diseases, no deep venous thrombosis, no lipid, liver, no problems are there. That woman who is perfectly healthy, can she take OCPs at 25 years for conception? Perfect. So, this is no contraindication. She is a healthy woman and she can take COCP. So, that is medical eligibility criteria 1. No restriction for use. Let's go and see medical eligibility criteria 4. Let's say a woman is having active PID. She's having a vaginal discharge, foul smelling discharge. But she happens to come to you and say, sir, I don't want to have children. I have one child. I don't want to have any more children. I heard IUCD is a very good method of conception. Can you put an IUCD? You examine her and you see that she's got a foul smelling discharge. She's got active PID. Are you going to put a IUCD inside and flare up the PID? You irritate the uterus and cause her to have sepsis actually if you put an IUCD that time. Will you put an IUCD? No, sir. This is contraindicated in active PID. So that is MEC4. Absolute contraindication to put IUCD when the woman is having an active PID. So unacceptable. So not to give MEC4 can be given MEC1. In between is the MEC2 and MEC3. What is MEC2? That there is benefit of this method more than the risk. So the advantage outweigh the risk. That's the basic meaning of this. I've highlighted the things. And MEC3 means the risk outweigh the advantages. So it's better avoided. So they'll keep asking. I mean, it's a very big chapter of contraception. People who are reading contraception, there are 2-3 famous books which are quite thick, and it's a whole subject to be read, contraception, and every method in common situations, is it MEC1, MEC3, MEC4, like that, they can be asking, but mostly they'll ask you about the regular things which are coming in the exams. So we are discussing just that today. So MEC1 to MEC4 are the eligibility criteria. So if they ask you what is the medical eligibility criteria of OCPs for a newly married woman, it is MEC1, that kind of thing. Okay, chalo. With this basics, now let's get into the natural methods and then we'll get into the hormonal methods. So I hope all of you get into the mood and stop the distractions, because next is hormonal conception and I'll be trying to make sure that you understand the basics. So just after this, no more distractions, right guys? So natural methods are coitus interruptus, that when the person is having intercourse, when he's about to ejaculate, he withdraws the penis and he ejaculates outside the body of the lady. So that is what is coitus interruptus. What is rhythm method or the calendar method? That 11th day to the 16th day of the cycle, you don't have sex. Okay, this is banned. Sex is banned on this day, before this day, and after these days she can have sex. So that is known as the fertile period method, or also known as the safe period method. This is fertile period, after this and before this is safe period, and it is also known as the calendar method or the rhythm method. All right, fine. Then the cervical mucus method or the Billings method. When the cervical mucus is thin and watery, the sperms will go inside easily. All right, all of this has been discussed in the menstrual physiology chapter very nicely, but I'm just quickly revising also. So when there is a cervical mucus which is present in the cervix, it will allow the sperms to go inside nicely. It is thin around the time of ovulation and it is thick after ovulation. So when the cervical mucus is thin and watery, the woman feels somewhat moist in the vagina. There is some wetness in the vagina. So those days when she is feeling subjectively moist in the vagina, those days she will not have sex. So yes, cervical mucus method or the Billings method, wet days. Wet days, no sex. That is one method the woman can herself understand and follow, because she knows that the day she's having subjective wetness, the doctor has said that this is the time when she's ovulating, because around the time of ovulation and before, the estrogen is high, estrogen makes the cervical mucus thin, and that thin mucus makes the woman realize that she's having some amount of moisture in the vagina. So those days not to have sex. Dry days she can have sex. Ovulation detection method like the urine LH kits she can use. Urine LH kits are there, or there is this basal body, yes, basal body temperature, the rise of 0.5 degree Fahrenheit, 0.5 degree Fahrenheit after the day of ovulation, that is also suggested that she's ovulated. So some home ovulation detection kits are there. With that, she can find out if she's ovulating. Around the time of ovulation, she avoids sex. Then lactation amenorrhea. Yes, you know that when the woman is lactating, there is high prolactin, and this high prolactin will inhibit the pituitary, basically by inhibiting the GnRH. So high prolactin inhibits the GnRH, and inhibition of GnRH will reduce the FSH and the LH. Both are reduced. So when there is no FSH and no LH, there is no ovulation. Now the problem with lactation amenorrhea is it is not a very reliable method, because it is based on constant increase. Yes, there should be a constant increased prolactin, but that is impossible. For constant increase in the prolactin, the baby should be constantly breastfeed, something like 24 times in 24 hours. No mother in the world can breastfeed like that. So this mother will breastfeed, let's say 7-8 times during the day, and maybe when she sleeps, let's say at 10 o'clock and gets up in the morning at 6, so she slept for 8 hours or 9 hours. In the sleep, she may breastfeed the child once more if the baby cries in the night. So she is breastfed only 8-9 times or 10 times in a day. It is still much lesser than what is required to keep the prolactin constantly high. To understand this, guys, the continuous suckling on the breast by the child will increase the prolactin, and that prolactin inhibits the GnRH and stops the ovulation. But no mother can breastfeed such regularly. There is no constant rise of prolactin after delivery. Yes, this is also an MCQ which has come in your NEET exam. There is episodic rise of prolactin when the baby breastfeeds. Episodic rise, and that episodic rise every time the baby suckles inhibits the GnRH. So continuous constant increase in the prolactin inhibits the GnRH and stops the ovulation. But that kind of breastfeeding nobody does. So that's why there can be occasional ovulation when the mother is breastfeeding also. So that's the reason. It's a somewhat long reason. Rewind and play again, guys. No problem. You must understand that lactation amenorrhea is not a foolproof method of contraception. That's why a lot of people, a lot of these women who delivered their first child, they'll come to me after 7-8 months and they'll say, sir, now I have breastfed, like you said, I must breastfeed the child exclusively for 6 months. Now it is 8 months, so I must talk to you about the other things I can give my child to eat and drink. Okay, fine, I give that advice. After that, sir, I also don't want to have another child for the next 2-3 years. So can you give me some methods of contraception? I said, why didn't you come to me? I told you to come within 6 weeks of your delivery for contraception. Why did you not come to me earlier? Sir, abhi to I was breastfeeding the child, so that is itself a protection. And anyway, I have not had periods. It's 8 months, I have not had periods, so pregnancy kahan se hogi? I ask her the next question. Have you had sex in these 8 months? Oh, fairly regularly we are having sex, sir. They're continuously regularly having sex, and she's not had period for 8 months. I do the pregnancy test and it comes positive for so many patients. And that's when I tell them, welcome to the antenatal clinic again. It happens so many times. Women take lactation amenorrhea to be, guarantee that she'll be not getting pregnant if she has sex. So please do not bank on lactation amenorrhea. Listen to this segment again, rewind and play again. Now, abstinence is also a method of contraception. You can advise, and if they can follow, great. Otherwise, that is the least popular method of contraception. I'm sure you can understand that. So those are the natural methods. Now let's get into the discussion of hormonal contraception and use of combined pills, progesterone-only pills. These are the hormonal contraception. And the first generation of oral contraceptive pills were the estrogen alone pills. 50 micrograms or more was required. was given, rather 50 micrograms or more. This is that amount of estrogen which was decided it will go and suppress the FSH and the pituitary won't work and ovulation won't happen. So that's what was done. 50 to almost 75, sometimes 100 micrograms tablets were given. That is the first generation. The next generation pills were the 30 to 35 microgram, and the progestins were, progestins means artificial progesterones. They were like levonorgestrel and norgestimate. Now the third generation pills are the estradiol, which are low dose. Guys, the word of the evening, this has to enter your genome right now. 6:20 p.m. in your genome, we are giving low dose estrogens these days. There is a lot of significance to this low dose word, which I'm going to just be discussing in the next slide. Okay, so estradiol 20 to 30 microgram, and progestins are like the desogestrel and the gestodine. These are the newer progestins. These are the newer progestins. Okay, then the fourth generation are the new third generation pills, which have the, they are actually called the fourth generation, but they're actually the new third generation pills. And there you have estradiol of, again, same 20 to 30 micrograms, but the progestins are like drospirenone. Now, drospirenone is a progestin. It's a progestin which is given generally around 3 milligram dose along with the ethinyl estradiol. Plus, it has got a anti-androgen action. We have discussed this in the chapter of PCOS also. And it has a anti-mineralocorticoid. It has got an anti-mineralocorticoid action also. So what is the benefit of this? You know, anti-androgen action will take care of the hirsutism in a lady. So we use this tablet a lot, this estrogen and the progestin called drospirenone. The combination available in the world is like Yasmin. Okay, it's a trade name. India, we have a Yamini kind of a tablet trade name which is there. So these tablets are good for the girls who have PCOS. So they help in the regularity of the cycle, because OCPs, you know, will make the cycles regular. And they also give the effect, added advantage of being anti-androgenic. So acne is also taken care of, hirsutism is also taken care of. So it's a wonderful new drug. Then what else? Anti-mineralocorticoid activity. So mineralocorticoids, yes, aldosterone, it's known to keep sodium and water inside the body. So anti-mineralocorticoid action means there will be some loss of fluids. What is the benefit of that? She does not have water retention. A lot of women, they say, I feel bloated, I feel some weight gain because of COCPs. I mean, weight gain ka to there are many other reasons, but they keep blaming my COCPs. So thank God for these new pills, that these new pills are actually known to help in weight reduction also, because water retention is not there. And this action, so that the water is less, they are also very good. They're very good for women who are having a lot of premenstrual syndrome. The premenstrual, very good for this one, because premenstrual syndrome is more with water retention. So this benefit, anti-mineralocorticoid action, is going to help the woman have a much better premenstrual time. So that's why these pills are the hotshot favorites. All right, so that's about the types of pills. Let me see, what are you guys asking? Arya Kumar, hello, I'm Dari, good evening for generation. All right, fine. So you're not asking me much, so let's get into the discussion of the hormones, the chapter of the evening. So when we're talking about the hormonal contraception, all these pills I told you just now. So when we're talking about this, let's quickly see the basis of the menstrual physiology. And now concentrate. I see a few of you are watching this, and those who are watching this as a recording, please, this is the moment. I've asked 3 times before, concentrate now, no distractions. So hypothalamus from the mediobasal nucleus, known as the arcuate nucleus, is going to stimulate the pituitary by GnRH. It's a pulsatile release, and this pulsatile release is 1 in 60 minutes in the follicular phase and once in 90 minutes in the luteal phase. Faster in the follicular phase and longer in the luteal phase. So F for faster, L for longer. Okay, it's a pulsatile release, acts on the pituitary. Pituitary will get stimulated in the initial part of the month to make the FSH. Follicular stimulating hormone will make the follicle grow in size. Growing follicle makes estrogen. High estrogen acts on the uterus to cause the proliferation. I have written that. And then this high estrogen gives a message to the brain. Hey brain, stop sending me FSH. I have grown big enough. I'm mature enough. Please stop stimulating me anymore. So brain says, okay, fine. I'll stop the FSH. Now the follicle also gives the message to the brain. Hey brain, send me LH. I want to rupture and release the egg. Why should I send you LH? How do I know that you are mature? Arey bhai, I'm sending you the required amount of estrogen. I'm sending you the required amount of estrogen, which is telling you that fine, the follicle is ready. Send me LH. So for the LH to come, there is a required amount of estrogen which gives a message to the brain. So this high estrogen gives a message to the brain to send the LH. So you must remember this, that this high estrogen is positive feedback for the LH and negative feedback for the FSH. So that LH comes out, it acts on the follicle, it ruptures the follicle, yes, to release the oocyte, and now the follicle will shrink and become the corpus luteum, which makes progesterone. And now corpus luteum makes the progesterone, which will act on the uterus to make the endometrium secretory. So yes, the endometrium becomes secretory because of the progesterones, and this high progesterone will give a message to the brain, which will be reducing the LH. So I have always told you these two lines. Do not forget these two lines. The purpose of FSH acting on the ovary was to make estrogens. FSH is to make the estrogens, and the purpose of LH is to act on the ovary to rupture the follicle and make progesterones. The purpose of the LH is to make the progesterones. Outright basics of my classes. Punchline of gynecology. With this, you understand so many fundas. So those who have read before the app or have seen me somewhere otherwise, please remember these two punchlines. With this, we will be managing a lot of our gynecology. FSH for estrogen and LH for progesterone. That is the basic. All right. Now, let us see what happens when I do a quick revision. What happens when I give some tablets from outside? Okay, once more, repetition. FSH is going to act on the follicle is going to grow big, and that is going to make estrogens. That estrogen is going to act on the uterus to cause the proliferation of the endometrium. Now, the LH will increase, will act on the follicle and rupture the follicle to release the oocyte and become a corpus luteum, which is going to make progesterone. That is going to act on the uterus to cause the secretion. Quick revision, right guys? Now, suppose I give this woman a tablet of estrogen to eat. I give her one tablet of estrogen to eat. This estrogen, when it gets absorbed into her body by the gut, it goes into the circulation and it gives a message to the brain that there is estrogen. The brain gets a message, oh, there is estrogen. What's my need to send any more FSH? So this estrogen tablet which I give will give a message to the FSH. It will inhibit the FSH. There will be no follicular formation. So when there is no follicular formation, there will be no estrogen formation. So that means when there is no follicular formation, that means the woman is anovulatory. Consider it, guys. Topic को पकड़ के बैठो, छोड़ना नहीं है. इधर उधर नहीं देखना. No questions. Listen to me right now. No, I don't want any. I'm not looking at the chat. No questions. No, I don't want any questions. Listen. Very important part of the class. पकड़ के रखो topic को. So when I'm saying the estrogen is high, it is going to give a message to the brain. It is going to suppress the FSH. And when there is no FSH, there is no ovulation. That means the woman is anovulatory. So now the woman has become anovulatory. Now, in addition to giving estrogen, I give this woman a tablet of progesterone. This progesterone tablet, when it goes into the body and gets absorbed in the circulation, this gives a message to the brain to stop the LH, because the purpose of LH is progesterone. So when I give this progesterone, it stops the LH. That means there is no corpus luteum formation. When there is no corpus luteum formation, of course, there will be no progesterone formation also. But if there was a follicle in the body, that will not rupture also, because you reduce the LH. You make sure that the woman is anovulatory. So when the woman is anovulatory, don't you think you have achieved contraception? Yes. And don't you think we can call this estrogen progesterone combination as combined oral contraceptive pill? So yes, guys, that is the basis of the COCPs. FSH for estrogen, LH for progesterone. I give this woman to eat the tablets of estrogen and progesterone from outside. The tablet of estrogen which I give stops the FSH. The tablet of progesterone which I give stops the LH. There's no FSH, LH, no gonadotropins. So gonad ovary will not work. That means there will be no follicle and there will be no pregnancy when she has intercourse. Also, when she does not ovulate, she'll not release much prostaglandins during the time of ovulation, which are released, they'll be not released. So that's why the cycle will also be much less painful. Yes, the cycle will be much lesser painful. So anovulator cycle, contraception, you understood, I'm rubbing it off. But remember that the cycle will be much less painful. Dysmenorrhea will be released because anovulator cycles are painless. Now, after understanding this part, can you just remind me what is the major source of estrogen production in the body of the woman? Any woman, the major source of estrogen production are the ovaries. The follicle on the ovary has the granulosa cells which are converting the androgens to estrogen to make the estrogens. So that estrogen is majorly made by the ovary in any woman. So what is happening in this woman who is on a combined pill? When I am giving estrogen, the pituitary, FSH and LH, when I'm giving estrogen, FSH is not working. When I'm giving progesterone, LH is not working. So when I'm giving this COCP, it is inhibiting the pituitary, FSH and LH. When there is no FSH and LH, that means there is no follicular formation. So with this drug, the pituitary is sleeping, the ovary is sleeping. So what is the major source of estrogen in this woman now? Once again, what is the major source of estrogen in the woman? The follicle. Is the follicle working in a woman with COCP? No, sir. You've inhibited the pituitary. Pituitary is sleeping. The ovary is sleeping. So there is no follicle. So there is no estrogen production by the ovary. What is the only estrogen in this woman? My pill. My pill is the only estrogen in this woman. Yes. So that's what you have to understand. Think, guys, think properly and understand. When I give this estrogen progesterone and it is inhibited the FSH and LH from the pituitary, it is inhibited the follicular and the corpuscle formation, it is inhibited estrogen and progesterone formation. So what will stimulate the uterus to make the endometrium and periods? How will she have periods, guys? You are telling me the periods will be painless. Arey bhai, mujhe batao periods hoga kaise? How will she have periods? You have stopped the pituitary from working, you have stopped the ovary from working, there is no estrogen, there is no progesterone. How will she have periods? Yes, you have stopped the ovary from working and making estrogen progesterone, but what are you giving from outside? You're giving estrogen and progesterone from outside. So my tablet of estrogen causes proliferation, my tablet of progesterone causes the secretion, and when you stop this, she has menstruation. So she will have periods, but the periods are because of these pills. The periods are because of these pills, guys. Please understand this. It is a pill period. I often use the term artificial periods, and I'm so happy that sometimes when students join our postgraduate course, and in the rounds they will tell that, sir, you have given COCPs and you're making her have artificial periods. Yes, I'm so happy if you understand that. These are not natural periods. The periods are banked. They are based upon the pills which I'm giving. My pill is giving her the periods. So yes, this endometrial proliferation and secretion is due to the exogenous estrogen and progesterone. This exogenous estrogen progesterone is making the endometrium proliferate and secrete. And when you stop this, there is shedding. So that's why it is called the pill period or the artificial cycle. That is a term which is not there in the books. It is just something which I keep using to explain all of you. It's not a natural cycle. It's a pill period. It's an artificial cycle. Now, guys, again, what is the major source of estrogen production in the body of the woman? It is the ovary. Is the ovary working in this woman? No, sir, ovary is not working. So what is happening? My pill is suppressing the pituitary and the ovary to work. So my pill is the major source of estrogen in the woman. Wait a minute. My pill is the major source of estrogen in the woman. And that is what is giving her the periods. Right? You understand that? My pill is giving her the periods. So if my pill is giving her the periods, then I give my pill in a very smart method. If my pill is giving her the periods, I give this pill for 21 days. See what happens. I give her this pill for 21 days and I stop. By 27, 28 days, she gets periods. Wait a minute. I give the pill for 21 days, stop, she gets periods. 21, stop, periods. 21, stop, periods. 21, stop, periods. Is getting a very regular cycle, guys. Yes, this cycle is totally under my control. I am giving a estrogen progesterone which has suppressed the body's formation of estrogen progesterone. So my pill is giving her the endometrium proliferation. And when the endometrium proliferation is happening, it is because of my pill. I give for 21 days and stop. She gets periods on 28th day. So that's why the cycles are regular, because of COCPs. You guys know this so well. Even if I had not taught you this, I had just asked you, what is the method of making a woman's cycle regular? You would have said, sir, give OCPs. They are the drug of choice for irregular cycles. Correct. Now you know why do they work like that. Because the period is under my control. The period is totally under my control. That's why she's getting this regular cycles, right? So give COCPs for 21 days and then we stop. Then the withdrawal is by 28th day. That's why it is a much regular cycle. It is a much regular cycle. Wait a minute. Wait a minute. There is something more. If you understand that when I give her the tablets, that is the major source of estrogen production in the body of the woman. And when I stop the tablet, she gets a period. So I give them for 21 days and stop, she gets periods on 28th day. These are regular cycles. This much you understood? What is the dose of the estrogen which I am giving to suppress the FSH? Should I give the highest dose, a very high dose, which goes and suppresses the FSH? Or give it the least dose, which goes and suppresses the FSH? We give the least dose. We use the least dose, which is going to suppress the FSH. Yes, I'll tell you what is the benefit of that. Okay, so let's go and see. So when this FSH is not there, ovary is not working, estrogen production is not there, and when the LH is not there, corpuscle is not there, progesterone is not there, my estrogen tablet is causing the proliferation and my progesterone tablet is causing the secretion. Yes, quick revision, you understood that? Now, when I'm saying this, please tell me how much of estrogen I'm giving. I'm giving the least dose, which is going to suppress the FSH. So I'm giving ethinyl estradiol only 0.03 milligrams. All right, which is actually, sorry for the disarray, 0.3 means actually 30 micrograms and 0.02 means 20 micrograms and 0.01 means 10 micrograms. All right, this should have come here. I think I changed the slides and it moved away. Okay, I beg your pardon. Anyway, I'm giving only 30 microgram, 0.03 milligram or 30 microgram. I'm giving the least dose, which is going to suppress the FSH. So what is the net amount of estrogen in the body of the woman when I'm giving her COCPs? If I'm giving COCPs from outside, I'm giving a tablet of estrogen progesterone from outside, COCPs, they are suppressing the pituitary and making the ovary not work. Am I using a highest dose or the least dose? I'm using the least dose, which can cause the suppression. So when I'm giving OCPs, that's the only estrogen source in the woman and I'm giving the least dose. So that's why the net amount of estrogen given to the woman is very low. So the net estrogen in the woman is low. Don't say if you give COCPs for 5 years, she'll have side effects of high amount of estrogens. No, man. If I'm giving her estrogens for a long time, this COCPs for a long time, let's say I'm giving her COCPs for, let's say, for 10 years. For 10 years, I'm giving her only 30 micrograms. So 10 years, she's going to have low estrogen in the body. Don't say if you give continuously COCPs, so estrogen is given for 10 years, that means high estrogen, so estrogen ka side effect ho jayega. Arey nahi yaar. Don't think that way. I'm giving a low dose. Look, you're used to eating, let's say, 4 chapatis a day, 2 for lunch and 2 for dinner. And you've been taking 4 chapatis all your, you're now intern, let's say you are around, finally an MBBS student, you are around 23 years of age. And 22, 23 years of age, you've been eating 4 chapatis daily. Now, I put you on 1 chapati a day, low dose. And I give you 1 chapati a day for 10 years. So what is happening now? You're having 1 chapati a day. Is it more or less than 4 chapatis? It is obviously lesser. So that kind of logic you have to understand here, man. I'm giving her estrogen at a very low dose for 10 years. So if I give for 10 years, for that the net amount of estrogen for the 10 years is low. Low estrogen situation when I'm giving COCPs. Please understand that. That's why you'll understand the benefits. You don't have to mug them up with a mnemonic anymore. You will understand them. Yes. When I'm giving her COCPs, the net amount of estrogen available in the body is low. So that's why we have a lot of benefits with COCPs in addition to getting the contraceptive benefits. So yes, when I give COCPs, it's a low estrogen situation of the body. Let's say I'm telling Mala N, it is the tablet which I was showing you there. So there is low estrogen, so endometrial proliferation every month will be less. That means there will be less bleeding and lesser anemia. Now, if there is proliferation less, then hyperplasia cases will be still lesser. So, there will be lesser hyperplasia and there will be lesser endometrial cancer. Now, when estrogen is lesser, it will also help in reduction of ovarian cysts and ovarian cancers. Less estrogen also means lesser colonic cancer. Hot shot, guys. Just put any number of stars and arrows and VIMP. It is coming. It came twice in the last year. I think it came, once in INICT, it came once in MCI. That, yes, in the last July MCI it came. Which of the following benefits are there because of COCPs? Which cancer is reduced? Colorectal cancer is reduced. Estrogen pills will bind the secondary bile acids in the gut. So, when the secondary bile acids are lesser in the gut, so that is lesser teratogenic for the gut. And also, they also are known to this, estrogens are known to inhibit the cancer cell lines. When the colonic cancer cell lines are inhibited in vitro, if we say, in vitro when we seen, they are known to inhibit the cancer cell line proliferation of colonic cancer cells. That's why CA colon is lesser with COCPs. Also, the other benefits are the reduction of benign breast diseases, but this is that very important thing. We are going to come back and discuss fibroid and endometriosis later sometimes in this Furray series. So, when we are talking about fibroids and endometriosis, they are classically in hyperestrogenic women. Classically, these two diseases in gynae are because of high estrogen. So, both these conditions, when you read, I'll be telling you the treatment is to reduce this disease by giving COCPs. So, if you give COCPs, they are going to reduce the incidence of fibroids and endometriosis. It reduces hirsutism and acne, like I told you earlier. It reduces PID because of reduction in the congestion of the pelvis and also benefit in rheumatoid arthritis. So, these are the benefits. These are the non-contraceptive benefits of low-dose combined pills. Now, maybe I'll see your questions. Yes. What if not give pills, no periods? I didn't understand your question, Tanisha. You'll have to ask me better. 7 to 14 day fertile. Why low is preferred? Why not high dose? High dose, Sudha Prasmanta, will cause side effects of high estrogens. I want to reduce estrogens for all these benefits. Na? And when I can give suppression of the pituitary by low dose, why give high dose? And I get so many benefits. That's why low dose. All right. But later the body will stop making progesterone estrogen because of pills mutation. Then what? What is that? I don't know what is pills mutation, my dear Tanisha. I have not heard of that. Maybe I have to start reading better. There's nothing called that. Pills will not cause any problems like that. There's nothing like a periods because of COCP. She'll not have periods or she'll not ovulate at all. No. 95% women recover within 3 months. Most women recover within the first 84 to 85% recover within the first month. And 95% recover within 3 months of stopping the COCPs, the ovulation. So, the rare problems of pill amenorrhea, that is something like 3-4 months she doesn't get periods. Post pill amenorrhea is described, but that is not common. I've yet to see more than one case. I think maybe one, and the second one maybe had some other problem of endometrial destruction. So, it's a doubtful case which I saw. The post pill amenorrhea is described, but not like what you're discussing. Please know the core basics first, Tanisha. Let's not worry about the rare complications. Okay, less chance of this will come later. High increased chance of clotting factors. Yes, you are right. I'm coming to the disadvantages. Yes, we are coming to that, my friend. How common those things are, we are discussing that. I'm just telling you so far what are your doubts. So please ask me about these things. Yes. How many months normally OCPs for PCOD? Now, Sutta Prasamanta. This is that one question. Yes. Thank you for asking me this question, Sutta. Lot of people say give COCPs, the periods will be regular. Right? And if you are interns, and some of you, if you are first PG and you are watching this, you have been taught that give COCPs for 6 months, periods regular ho jayega. Arey, it will be regular only for the 6 months when you give. How will you treat PCOS with just giving COCPs? If you give COCPs, the period will be regular because you're giving an artificial cycle. PCOS का treatment OCPs नहीं है, please. OCPs are not going to treat PCOS. It is going to suppress her natural, whatever is the method of her periods, it's going to suppress a pituitary and you're going to give artificial cycles. So, as long as you give the COCP, she'll have regular cycles. Moment you stop the pills, she'll go back to irregular cycles. So, whenever you're taught this, so many of you know this line. So, give COCPs for 6 months and the cycles will be regular for life. Nonsense, man. It never happens that way. If it is PCOS, it will not get corrected by COCPs. COCPs will give regular cycles only as long as you give this. COCPs. Now, this has to be understood. You're going to become gynecologists, man, and my students. You will understand better than what the whole world is talking. That OCPs, if you give 6 months, will cause regular cycles for the rest of her menstrual life. Nonsense. It never happens that way. It's only for the time when you give this, she'll have regular cycles. So, yes, if she wants regular cycles, she better take this pill regularly as long as she wants regular cycles. That's how it is. That's how it is. Yes. So, lifestyle modification will help in PCOS but not treat PCOS. PCOS is not, there's nothing like I give this tablet and everything about PCOS is over. No, PCOS is a syndrome. See the app. It's a very interesting chapter. Okay. Okay, fine. So, let's move on. So, these are the benefits of the COCPs, and let's move on and see other things. What are the rare side effects? Very rare side effects. Okay. Now, I'm going to speak with a lot of my experience also. In addition to, I've been in gynecology. I got into my PG in 1996. Ever since, it's now 30 years, and God bless, God forbid, this is what I've been doing all my life. So, please, these side effects are theoretical before I tell you also. You're worried that it's going to cause deep venous thrombosis. It is to people who are having a predisposing cause. They will have these side effects more than healthy young women. So, yes, let me just tell you that the adverse effects which are very rare is adenocarcinoma of the cervix, but not the squamous cell carcinoma. Please, the CA cervix which you see in the OPD, all your final year students and the MBBS students and the interns, that is squamous cell carcinoma of the cervix. The adenocarcinoma of the cervix very rarely can happen because of COCPs. Not because, do not say COCPs cause CA cervix or the squamous cell carcinoma. They can cause adenocarcinoma rarely. What is the most common CA cervix which we see in our country? Squamous cell carcinoma. Rarely because of this, there will be adenocarcinoma. There will be more gallstones, but not gallbladder stones. Gallbladder cancer, I'm sorry. There will be more gallbladder stones, but not gallbladder cancer. There will be more hepatic adenoma, but not hepatocellular cancer. And there will be more chlamydial PIDs. Look, I told you in the previous screen that there will be lesser PID, but chlamydial PID will be more. So, what is the meaning of chlamydial PID? Indolent PID, or also we call it the symptomless PID. All right, and then thromboembolism will be more, and there will be more deep venous thrombosis. Theoretical risk, all right, when they are predisposed. So, yes, if there are those thrombophilia kind of patients, and if you don't know and you've given them, then maybe they will have. Not for any normal woman. I've yet to see a normal woman having these side effects. Okay, I'm teaching you this, but they are not common at all. So, thromboembolism, the venous thromboembolism is because of the progesterone component of the pill, and the arterial thrombosis is because of the estrogen component of the pill. Then the usage of this pill, how do we give this pill? So, usage. So, in addition to having this understanding, we should know how do we start the pill. So, the pills are ideally started on first day to the 5th day of the menstrual cycle. So, the girl gets her periods, suppose on 1st of Jan till 4th or 5th of Jan, anytime she can take the tablet, start the tablet. So, yes, remember, it takes 7 days for the effect to establish. It takes 7 days. So, when it takes 7 days for effect to establish, that is the basis of many things coming later. So, suppose a woman says, I'm going to get married, and I'm going to get married on 3rd of Jan, and I'm going to be sexually active, let's say 4th of Jan onwards. So, I want to start a pill. My period came on 1st of Jan. So, I tell her that you take the pill, but till 7th of Jan, if you have intercourse, you must use some other method, because the effect of the pill has not yet established. But that's only for January. Next time when you take the pill, let's say for Feb, that time you're already protected. Now, for that first 7 days of Feb and the first 7 days of March, first 7 days of April, you don't have to follow that protection. Only for the first time when you start the pill, this rules lasts. Then there is something called the quick start protocol or the random start protocol. Any time of the month when the woman comes to me, I start the pill. This is generally reserved for people who are not reliable. They're not going to come to you for follow-ups of contraception, especially our, the uneducated strata of the society, the low socioeconomic status, and even the teenagers, because teenagers who are sexually active, they might be having a lot of sexual exposure, and they come to you for infection management. Even as recent as yesterday and today, we saw some teenagers in the OPD, and those people, we told them that, to advise them to stop having sex, they may not follow, but at least be careful not to get pregnant and don't have infection. This is the advice you must give these youngsters who have intercourse early in life. So yes, we give them COCPs even if they're on the 10th day of the cycle or the 15th day of the cycle. Pakad mein to aayi, be patient, so that she's at least under some COCP. No sir, if you start on the 10th day, then the pill is for 21 days. That means 10 plus 21 is 31 day ho gaya, and period will come on the 38th day. Yes, for the first time it will come like that. It will come delayed, yes, because I started after 10th day of the cycle, correct? Hoga. Once only, na? Next time she'll be following the pill properly. Then she'll have regular cycles. But at least I caught her, and I'm preventing unwanted pregnancy. So that is start any time of the menstrual cycle. The advisable mainly for the low socioeconomic status and the teenagers who are not compliant. Now, very important part of the class, missed pills. If the person who is regularly taking the pills, let's say for 3 years, she missed one pill, so take 2 today. If she misses 2 pills, then also take 2 tablets today. Now, what happens if she misses 3 pills? Please don't say take 4 today. Don't say that if she misses 6 pills, she takes 7 today. There's no such law, okay? If she misses 1 tablet, she takes 2 today. She misses 2 tablets, again she takes only 2 tablets today. If she misses 3 tablets or more, oh hello, she is not taking estrogen progesterone tablet from outside, and that estrogen progesterone tablet is going to cause the suppression of the pituitary and suppress the ovulation. If you do not take the tablet, if the woman is not taking the tablet for 3 days, then the pituitary wakes up from the suppression and it gives a rebound high FSH, and she may actually ovulate very early. So yes, that is a cause of the failure of the pill now. So if 3 days or more are missed, the effect is lost. That is what is very important to understand. So 1 day missed, take 2 today. 2 days missed, take 2 today, not 3. 1 or 2 day missed, take 2 today. If it is 3 and more, first remember the contraceptive effect is lost. So what do you do now? Tell her to take 1 pill, the day's pill. She's not taken for the last 3 days. She comes to me on 21st of Jan. I tell her, okay, fine, take today's 1 tablet. Now don't miss the pill. Continuously take the pill, okay? No more missing. So, okay, I will remember, sir. But remember, now the contraceptive effect is lost. So, we'll take again 7 days for the effect to establish. So, for the next 7 days, use another method of contraception, because it takes 7 days for the effect to establish. But if she misses 3 or more in the 3rd week, now that is what is if 1st week, 2nd week, and the 3rd week. And then there is 7 days of ferrous sulfate. So that is how we keep the month of a patient with PCOS. This is the time when we're giving her the active principle, that is a COCP, and the last 7 days there is only ferrous sulfate tablets. Now, if she misses on the 1st week, 2nd week, follow this protocol, this one. If she misses in the last 7 days, you tell her that she's missed the pill. How many days you miss? Sir, I missed for 3 days. Okay, take 1 tablet today. Do not give a gap, because now when you're taking it in this last, suppose she's missed it here. She comes to me, let's say on the 18th day of the cycle, saying I've missed for the last 3 days. I tell you, take 1 pill today. She takes 1. Now continue the tablet. She takes it on 18th day, 19th day, 20th day, and the 21st day. But she says, sir, after 21 day, I'm supposed to take a gap of 7 days, that ferrous sulfate. No, now don't take a gap, because the effect will establish only in 7 days. And then you again give a 7 day gap, again the effect will be lost. So if you miss the pill in the last 7 days, then the gap of those 7 days, that ferrous sulfate days, that is not given. Okay, so if she misses in the last 7 days, she takes one tablet, she continues the pack, and she discards those extra iron sulfate tablets, and she continues for 21 days without a gap, so that the effect is established and there are no breaks. Okay, so take one pill today, next 7 days use alternative method just like this, but since it is the last 7 days, avoid 7 days break. Okay, avoid the 7 days break. All right, so let's first 7 days out of the way, then another method also along with. Yes, first 7 days, first time when you start. Yes, mother had some problem, leg spots on the legs. Yes, those can be because of any drugs. Leg spot, what was the etiology, my dear? Fixed drug eruptions. There can be so many other drug reactions to any tablet in the world. Yes, I'm not saying OCPs are without any side effects. Even if you take Kroener, it will have side effects, my dear. So hypersensitive reactions can be there to so many things. So if the person has taken for some time, she had some spots and then you stopped, they went away, it is an allergic manifestation. That can happen to it. I am talking about long-term use of OC pills, and if they have any side effects, they are very rare. I mean, there are no immediate hypersensitive reactions. Now the person is having a protection. COCPs, no pregnancy is happening. Now she's continued taking for 3, 4 years, 5 years, 10 years, and the side effects are very less. Hypersensitive reactions can happen to any tablet. Even ranitidine can cause. We take it for gastritis, like, you know, we keep popping in ranitidine because we have this gas ka problem, isn't it? And then that can also have side effects. Any drug can have a side effect. Iron sulfate can have side effects. Folic acid is known to cause side effects. Hypersensitivity alag hai yaar. Side effects of OCPs given for a long time, those are different, right? Okay, now wait. Let's not get distracted. The very important part coming. Okay, don't stop. Wait. Missed one pill, take 1 or 2. Sorry, missed 1 day or 2 days, take 2 tablets today. Missed for 3 days or more, I explained everything to you. What if she has missed for 3 days and she's had sex in these missed pill days? The contraceptive effect is actually lost because she's missed for 3 days and she had sex, and comes to me, sir, I didn't take the pill for 3 days. There was a a family function going on and I was very busy at home, so I forgot to take the pill. But they managed to have a physical relation, missed the pill, had physical relation. What happens? She's not protected and she had sex. So now, in addition to giving all of this, you have to give emergency contraception. So if 3 or more days are missed and she had intercourse on the missed pill days, then give emergency contraception also to prevent a pregnancy from happening. Okay, so emergency contraception is also given. That's extremely important part of the discussion. All right, chalo, let's move on and see contraindication to COCPs. I've given you first itself, age more than 35 years and she's a smoker. No, what happens that any woman who is, let's say around 40 years and more, we don't give COCPs because the theoretical risk of coronary artery disease will increase, and also the risk of this side effects will increase more. So after 40, COCPs are generally not given for contraception. We generally avoid. But if a woman is a smoker, she's as it is increase the risk of coronary artery diseases. So we don't give smokers OCPs after 35 years. All right, excuse me. Then what are the other contraindications? Pregnancy you won't give. Breastfeeding you will not give. The estrogen component, yes, estrogens will reduce the prolactin. So breast milk formation won't happen. Also they cause mammary. There's a mammary gland involution. There's a mammary gland involution which can happen because of these estrogens. So the shrinking of the mammary glands can happen. So that's why it's avoided. So estrogens are classically not given. If at all you want to give oral pills, we give them progesterone only pills, right? Then we have the deep venous thrombosis, which can happen, pulmonary embolism. So that's why it's a contraindication. Now liver diseases will not give any estrogens because estrogens are metabolized in the liver. So that's why in liver diseases. And then hypertension, that is blood pressure more than 160/100. So MEC2, if it is 159/99 like that, and MEC 4 if it is more than 160 by 100, like that. So there are these sub classifications are there, but roughly mild hypertensive can be given, but the hypertensive which is more than this should not be given. Mild hypertension is not a contraindication. Then right, active breast cancer we cannot give, because any type of estrogens are not given in a woman who's got breast cancer, because most breast cancers are estrogenic. So in a follow-up of breast cancer after treatment also, COCPs are not given. Uncontrolled diabetes with nephropathy and neuropathy, uncontrolled lipids also you don't give, and ischemic heart disease with stroke, migraine with aura, these are all the contraindications. So remember, diabetics who are controlled I can give. Yes, COCPs are safe in diabetics. Controlled diabetes safe है, कोई problem नहीं. Uncontrolled diabetes, uncontrolled lipids we don't give. Okay, now what is not a contraindication is your MCQ. Not a contraindication for use are the STD, PID and HIV. This is absolutely nothing to do with the use of COCPs. Nothing. In STDs, HIV, you can go ahead and give COCPs. Right. I didn't understand this question, Sutta. So, to prevent fertility due to intercourse, how many months? I mean, you're trying to say that, huh? I mean, like, the effect established in 7 days. That's it. And you continue giving COCPs as long as she doesn't want to have children. She got married at, let's say, 25 years and she says, I don't want to have a child till I'm 32. So, she can take COCPs for 7 years. You can maybe, ask me this question somewhat better. All right. Chalo. So we'll see, we have many more things to discuss. So I don't want this to become a very long class. Let's see what else we can discuss. So Saheli, yes, that is Centchroman. Somebody wrote Saheli. Tanisha, did you see my presentation? How did you guess that I'm going to teach Saheli next? I didn't run the slide early. Good. So yes, Saheli Centchroman. It is developed by the Center for Center for Drug Research Institute, that is Lucknow, and that is known as ormeloxifene. It's a selective estrogen receptor modulator. So the salt is ormeloxifene. It is Centchroman. It is sold as Saheli by in the country. It is given many places. In some setups, it is given free of charge also. So it makes the endometrium out of. But ask the PSM people, they were the best people to tell you whether it is free of charge or not. Because in my hospital, we used to give it for free of charge. I'm talking about it's not a government hospital where I work for a missionary hospital. So we used to give it free of charge for some time. Of course, now we don't give any pills because we have to have a different kind of a setup for that. So this is mostly available in the market. But whether it is free or not, that is for the PSM people to tell you. So remember, it makes the endometrium out of phase for the endometrium. Endometrium is too secretory for the embryo. So embryo comes to a very fluffy endometrium for an implantation. So it doesn't implant. So there is an embryo uterine asynchrony with the ormeloxifene or Saheli. So we generally give it for twice a week for 3 months for the effect to establish, and then we give it once a week till as long as she wants to take contraception. But the side effect is that there could be some delayed cycles. Some of my patients, most of my patients who say that they used to get periods in 28-30 days, they generally get around 35 to 40 days periods when they give ormeloxifene, but it's a very effective drug. Yes, it's a very effective drug. So what are the permanent methods? So permanent methods are the sterilization methods, like the male sterilization, the female sterilization. I thought in addition to COCPs, I'll discuss the more important methods which generally come in the exams. So I'll just get into the sterilization surgery. And remember that mostly the sterilizations are done when a woman has 2 children. Now, there is no contraindication to have a sterilization done after 1 child. There is no such contraindication. A woman has delivered a first child. She says, sir, I don't want to have any more children. I want a tubectomy. Or a man says, I want a vasectomy. Can do. Advisable. Journal. Sound advice kya hai? You have your 2 children. Okay, we can do sterilization. But let's wait for the younger child to become 3 years old, because neonatal mortality is still quite high in the country. Some fever happens. Let the child get to be around 3-4 years, and then you can come for a permanent method. Till then you can take IUCTs, like that we say. Permanent sound advice is after 2 children, wait for the second child to become 3 years and then do the permanent sterilization. But nobody listens to this. People come to us after the, the 4th delivery also, we tell them to get a sterilization done. They say, okay, fine, aayenge sir, 6 hafte ke baad aayenge. And then they come to us only when they're delivering again. So yes, that's a problem in our country. The biggest problem which I feel, I am not supposed to speak about social causes on this education forum, but then all you students, MBBS students and interns, you'll all become administrators. Some of you will become the head of departments and the directors and of the institute, and you'll also become maybe into political posts, maybe the Director General of Health Services one day. You are the youngsters who are going to, so I feel that I'm doing my bit to push the one child norm in the levels where I'm working. You're happy to have two, you can have 6 or 7 children also. But my country, I feel now we should reduce the population, so that once we reduce the population, the resources are shared by limited number of people. And the sheer number of us is becoming a problem ever since independence. So if we are taking this seriously, it'll be great, right? So I want you guys to push reduction in size of the family. Okay, let's not get very political. I don't want to get into any more serious discussion about that. Okay, so all of us should take care of that. So permanent methods should be used with 2 children or afterwards. That's a sound advice, but not a guideline. Okay, it's a sound advice. So let us talk about female sterilization first. And when we talk about female sterilization, yes, Jessica, I'm so happy what you wrote. Very good. So female sterilization is where we do a tubectomy, which is tubal ligation or tubectomy. Look, I want you to understand the terms. Tubectomy means we just cut a segment of the tube like this. Salpingectomy means we cut the whole tube. So we are not cutting the whole tube, okay? We are cutting only the segment of the tube which we want to cut, so that we keep a window open for a reanastomosis later in life. Yes, that's what is the reason. We cut only a segment. Look, there is a woman who has, let's say, 3 children. And she says, sir, enough, I don't want to have any more children. My husband is not happy using condoms, and I will not remember taking any tablets. So, sir, why don't you just do a tubectomy? Ye kaat do, nas kaat do, like that they'll see in Hindi. I'll say, okay, fine. We'll cut your tube. But I cut the tube in a way that later, if she suddenly decides to have more children, so I can reanastomose. So I cut it only very small segment, and I cut it in a place where the reanastomosis is common, because suppose she lose the children unfortunately for whatever accident in life, or the woman has a divorce and the husband gets the custody of the children. She wants to have more children then. So we have done so many reanastomoses. It's a common surgery done in gynecology departments. So yes, tubectomy is just cutting the segment. Salpingectomy is cutting the whole tube. So for sterilization, we don't do salpingectomy. The only place where you guys have to know salpingectomy, total cutting of the tube, is rupture of an ectopic pregnancy. So please see the difference. So we are going to do a tubectomy, tubal ligation. So site of ligation is the isthmus. It is the isthmus. When we do the isthmic sterilization, okay, it's already written here. It is because it is of uniform diameter. So let me draw that to you so that you can understand. Uterus, vagina, and the fallopian tube. So this is the ampulla and this is the isthmus. So I will cut the tube at the level of the isthmus. When I cut the tube at the level of the isthmus, how is it useful? So when I cut the tube, suppose here, so the 2 cut ends are like this. They are of uniform diameter. So when the 2 cut ends are of uniform diameter like this, then for me to do a reanastomosis later in life for her, if I do the sterilization and the reanastomosis has to be done by somebody else, suppose, that reanastomosis is much more easier at the site of the isthmus, because the cut ends are uniform. Suppose somebody cuts at the isthmo-ampullary junction. Suppose it is cut here. So then the isthmus is like this and the ampulla is like this. So the reanastomosis is not very uniform. So that's why we say always do a isthmic sterilization. All right, uniform diameter. So isthmic reanastomosis is more successful. So it is up to 80% success if it is done at the isthmus. Okay. Oh God, that is also written. Never mind. So what is the timing? Yes. What are you asking me? You're not asking me anything for the timing, but just watching because studying medicine gave me happiness and satisfaction. Tanisha. All right, Tanisha. Welcome. Welcome. Okay, please tell more people who should be looking at these kind of lectures. I'm not trying to make it very tough. Yes, this is a medical lecture, but if you listen to us, you're most welcome. All right. And the others who are seeing it as a recording, you're more welcome. So timing of a tubectomy. When all we can do a tubectomy. So the most common time of doing a tubectomy in my country is the postpartum sterilization. Now, postpartum ligation or postpartum sterilization. See, when the woman delivers the uterus, look here, in pregnancy, pubic symphysis, normal uterus is say this size, and in pregnancy, the uterus is something like this. In fact, the flanks are full. See, these flanks get full. So that's the uterus inside the mother's abdomen. Now, what happens after delivery? So, after delivery, the uterus is just below the level of the umbilicus. The baby goes out and the uterus is just below the level of the umbilicus here. So, if it is just below the level of the umbilicus, let's say I'll try to show you. Okay, see here, it's like this. I'm trying to show you through my shirt. I've put my pen and showing you. So, you can put a hand on the mother's tummy like this and you can feel the uterus. Yes, you can feel the uterus here. So, what happens when you feel the uterus after delivery? It's just delivered yesterday, and today you go through rounds and you can feel it. So, if you can feel the uterus so easily in the abdomen, you can make a small cut here and go and take this side and this side tubes and do a very easy ligation of the tube, because uterus is an abdominal organ after delivery. So that's why we always keep asking you this question in your exams. Any exam you write, whether you're writing the final MBBS exam or you're writing your entrance exam, where is the uterus immediately after delivery? Immediately after delivery, it is just below the level of the umbilicus here. So we can make a small incision, mini laparotomy we call it, small incision, and we can cut this tube and we can cut this tube with the same incision. So that is why we will do more postpartum sterilization in our country than any other sterilization, because women come to the government hospitals for a free delivery. In fact, most of the women who deliver in the hospital, we give them some money. In spite of, in addition to free treatment, we give them some money. If a girl child is born, we give them more money. Isn't it? The government is very magnanimous and trying to help women deliver in the hospital so that they don't deliver in the villages and have PPH and die, or come to us very sick when much more resources are required to take care of a woman who have PPH and she's close to dying and she's in the ICU. Much more resources are required than her to deliver in the hospital, and we give her 5,000 rupees or 10,000 rupees after delivery if she's delivered a girl child. So, government is coming out with a lot of proactive schemes so that all mothers deliver in the hospital. That's why, when I was intern, when I was working, when I MBBS in MD from, yes, my MBBS in Japan, I'm telling you, 1994-95, when I was doing my internship, that time the maternal mortality rate was around 556. Then when I was doing my post-graduation, it came down to something like 330. Till last 2 years back, it was 97, came back to 93. Now it is 88. So yes, we are pushing women to deliver in the hospitals. So when they deliver in the hospitals, the chance of them having severe complication is lesser. So when they deliver in the hospital, the next advantage is that I can go for the rounds and I can see her uterus is felt and ask her, which delivery was this? She said, it is my third child. Okay, so how about I do a tubectomy for you? Dr. Saab, I don't want to come back after going home because I have got 2 more children. I have a lot of work. All right, we can do it today itself. It's a small incision under local anesthesia I'll do, and you'll not even see the cut after a few days. And it's a very easy time because the uterus is not inside deep into the pelvis. It is high in the abdomen. I can do a very easy tubectomy. I convince her, and then we give them some money, 500 to 600 rupees. I think the PSM people say now it has become 600 for the women who get sterilization, and it's around 1300 for the men. 1100 for the men who gets the vasectomy, 200 for the motivator who brings the man for a vasectomy. So we give them some money more. More money is given so that they get a tubectomy done. So uterus is just below the level of the umbilicus. Postpartum sterilization is the most common time. All these questions which I discussed are coming in the vivas. All right. Finally, yes, be careful. Then uterus is abdominal organ, and at this time, hence it's an easy surgery. Now the next question is, how long can you do this? I'm removing it now. How long can you do this? Only as long the uterus is the abdominal organ. So how long can you do? How long can you do a postpartum sterilization or a puerperal sterilization? As long as the uterus is in the abdomen. So how long is the uterus an abdominal organ? Only for 2 weeks, because in 2 weeks it becomes a pelvic organ. Don't say 6 weeks. We keep answering wrong this answer. So it becomes a pelvic organ in 2 weeks. So that's why around 7 to 10 days only we can do postpartum sterilization. Mostly we do today she is delivered, tomorrow morning or day after we do the postpartum sterilization. We can do maximum for around 2 weeks. Around basically it is 7 to 10 days, but we say roughly 2 weeks. Why? Because in 2 weeks it becomes a pelvic organ. When does it become a normal organ? It becomes a normal organ in 6 weeks. 4 to 6 weeks it becomes a normal organ. All right. So yes, I think these colors you're not able to see too well. I'll go back to black. So we can do this all that only for up to 7 to 10 days. So best done within the first 2-3 days of delivery, maximum up to 7 to 10 days. Why? Because in 2 weeks it becomes a pelvic organ. So both the questions come in your vivas. When does the uterus become a pelvic organ? 2 weeks. So how long can you do puerperal sterilization? Maximum 2 weeks. Okay, or 7 to 10 days as written here. Then what is the other method? I told you sterilization. Just now I told you which method? Postpartum sterilization, also called the puerperal. I'm telling you the timing of sterilization. Then we can also have interval sterilization, which is done after the 6 weeks of delivery, after the puerperium. It is commonly done by laparoscopy because it's a pelvic organ. It's deep into the pelvis. So we can approach only by a, this uterus can be approached only by a laparoscope. So it is done after 6 weeks of delivery and it is commonly done by laparoscopy. Now, concurrent sterilization, this is done along with MTPs or a cesarean section, or even some other, let's say somebody is getting an appendicectomy done. She says, sir, I have 2 children. Now I have this pain abdomen. You're doing a laparoscopic appendicectomy. She'll tell the surgeon friend to call the gynecologist. Along with that, we do a tubectomy also. So concurrent means along with any surgery. Mostly it is along with an MTP or a cesarean section, concurrent. So these are the 3 types of sterilization surgeries. One is puerperal, one is interval, and the other one is concurrent. Now, entry into the abdomen can be by laparoscopy or a laparotomy. In our country, laparoscopy has increased substantially. There are camps of laparoscopy across the country where surgeons will go, laparoscopic surgeons, gynecologists will go, or trained doctors who are MBBS, but they are with the they are the SMOs who are working for the government, and they go and do. So they are trained doctors who go and do these laparoscopic camps, but still the most common time women get the tubectomy done is postpartum. So laparotomy is still the major method in our country, and laparoscopy is increasing much higher, but still laparotomy is the more common method. So mini laparotomy, we say, we don't say cutting the whole abdomen, we make a small incision like I told you. So it is a mini lap surgery, 1.5 to 2 inch incision. So this is what they'll ask you. Write a short note on mini lap, or they'll ask you in the viva, what is a mini lap? Mini laparotomy, 1.5 to 2 inch incision. With that, you get into the abdomen, take out the tube, and after checking that you're cutting the tube, how do you check? You see the femoral end. You pull out the tube, check the femoral end, do the ligation, push it back inside with a mini lap. Laparoscopy also is a method of entry, but laparoscopy is not done in the puerperium because there's a high chance of failure because the tube is edematous. So if we generally put a ring on the tube. When you put a ring on the tube, that ring on the tube will slip out because of the edema of the tube. All right, so that's why the laparoscopy procedures are not done for puerperal methods. Also, there's a high chance of injury. Right. So what are the techniques of tubectomy? Tubectomy techniques, the most common technique done even now in the country is the Pomeroy's, but you have to know it is called the modified Pomeroy's. Nobody does the original Pomeroy's. Like there was this question about Shirotkar's cerclage. So it is not called Shirotkar anymore. It is called the modified Shirotkar. The great Dr. Shirotkar did a procedure, but the modification was found to have lesser infections. So most people do the modification. So it is called the modified Shirotkar now. So we'll never ask you in the exam difference between Shirotkar and modified Shirotkar. Not at least in a MCI exam, PG entrance exam, or the the exam which you're writing, the final year MBBS exam. We'll definitely not ask you there. So you have to know modified Pomeroy is the most common method in the country. So single ligate is used and both the ends are cut. So you see we use this forceps, Babcock forceps, to pick the tube and make a loop like this, and then we tie the tubes together and then we cut them. So what happens? These tubes are cut and they are tied together. Can you see this? They're tied together, and when the sutures dissolve, they'll get separated. But what is the problem? That they are together for a few days. So when they're together, there can be a theoretical spontaneous recanalization. That's why this modified Pomeroy's, it's not my favorite method. A lot of people also don't do this because of this theoretical chance. So the cut ends are together can lead to fistula formation leading to failure. Theoretical chance, okay. So let's not say that it's a bad thing to do pomeroy's, but it has a theoretical risk of a spontaneous recanalization. Then what is a Parkland technique? That's my favorite technique. Why? Because what I do in that, when you make a loop of the tube, you cut both the tube and you tie them separately. They are not together. From the day of surgery, they are separate. See, pomeroy's, they were tied together on the day of surgery itself. So there was a chance of recanalization. In Parkland, they are separate from the day of surgery. All right. So tubes are ligated separately in this one. Postpartum ligation can give permanent sterility. Obviously, yes, definitely. Permanent sterilization to karna hai. Method is permanent is Suta. The method is permanent. So it is for permanent sterilization. Yes, you can do a reanastomosis if she so desires, but that has to be done surgically. It is a reanastomosis, a major surgery. So till that is done, she will not conceive. Failure of a tubectomy, that is a side effect of any procedure. Like anything you do in surgery, there can be failure. The purpose is to give permanent sterilization, Suta. Don't get confused. So that is the Parklands. Pomeroy's and Parkland are the two techniques which are coming in your exam generally. But in MCQ exams, the other techniques also have to be known. I'll just tell you a few other techniques. I'm not telling you all of them. All right. So Irving's procedure is, that show-off procedure when you want to tell your PGs that you can do something very nice, So what we do is we cut the tube and one end is buried. The one end of the tube is buried into the musculature, uterine musculature. Another end is buried into the mesosalpinx. So see here, the tube is cut. One end has been buried into the uterine muscle. The other end goes into there is a mesosalpinx, basically the top end of the broad ligament. The mesentery of the tube is known as the mesosalpinx. So we bury it into the mesosalpinx. So in addition to cutting the tube, we bury it also. There's another method called the Uchida's method, subserosal dissection. It's all right. It's that under the serosa we do the dissection so that the top of the tube looks continuous, but inside it is cut. That is Uchida's. They are not asking all those vague names, but Irving's comes as a choice. Then Madlener's method and another method is the Kroener's method. There are two methods which are taught to you only to condemn. Don't do these two methods. So what are those two methods which are not to be done? One is Madlener's method. What is happening in the Madlener's method? You're just crushing the tube. You're not cutting it. See, tubes are only crushed, not resected. So if you just crush them, there's a high chance of failure. So that's why Madlener's is not done. This is not to be done. We don't do because high chance of failure, high failure rates. Then what is the Kroener's? Kroener's is the fimbrectomy. This is a favorite PG entrance question. What is the name of the fimbrectomy surgery? Just the name they'll ask. Why? Because you're cutting off the fimbria. See, the fimbria is gone. You throw the fimbria off. So even if she comes for a reanastomosis later, there's nothing to hold the egg later on. There's no fimbria. So you'll have to do a neofimbriostomy, which is a 5% success kind of a thing. That's why Kroener's fimbrectomy is also not done. So these are the methods of tubectomy which I thought to tell you. We can also do laparoscopic rings and laparoscopic clips. So let's see, if it is not there, then I'll tell you otherwise. So steps to avoid ligating other structures. Yes. So when we're doing a tubectomy and you made an incision and you're taking out the fallopian tube, so sometimes you can actually pull out the round ligament and ligate it. You can pull out the bowel also. So how do you make sure you're ligating only the tube? So when you pull out the tube, you pull it out so much so that the fimbria also comes out of the abdomen. When the fimbria comes out, that structure has to be ligated. That's the best way to make out. Again, question. All you finally MBBS students, these are the questions they'll ask you in tubectomy. How do you make sure that you're cutting only the tube? You pull out the tube. You can, whichever tubal organ you're going to ligate, you try to pull it out completely. So only the tube can come out completely. If it is a round ligament, it will never come out completely because it is going into the inguinal canal and going to the labia majora in front. The round ligament will not come out. It will come out only minimal. You will not be able to see any end of the round ligament because it cannot come out. You will tear it, but it will not come out. Similarly, if you pull out the bowel will keep coming out. It will not stop coming out. So whatever structure you are ligating, try to pull it out so that you can see the fimbral end. Once you see the fimbral end, then you ligate. Okay, so the method by which you pull it out is by the Babcock's forceps. Babcock's forceps. That is the atraumatic forceps, and that is what instrument test will come. The tip of this forceps is blunt so that when you pull the tube, it will not tear and it will not get crushed and not bleed. Babcock is also a favorite instrument of the surgeons for handling bowel because it is atraumatic. Okay, structures ligated by mistake when you're doing a tubectomy. What are the structures you can ligate by mistake? You can ligate the round ligament, which is the most commonly wrong ligated structure. You can ligate the small bowel. You can ligate the ovarian ligament. Appendix has been ligated a few times, many times actually, but some of the time we'll tell you those stories informally, all right, not on a formal forum like this. But yes, ureter, can that be ligated or has it been ligated while doing a tubectomy? Watch it, guys. This is the favorite. MBBS students, watch it. This is the favorite question your examiner is going to ask you. When you're telling about tubectomy, they'll say, okay, what are the structures you can ligate by mistake? They'll try to make you do this mistake. You'll say, sir, while doing a tubectomy, I can ligate the round ligament. Okay, okay, और क्या है? सर बावल ओवेरियन लिगामेंट यू कैन लाइगेट बाय मिस्टेक. नहीं और भी कुछ है, एक और ट्यूबल स्ट्रक्चर है, जो नीचे से जाता है, और वो ट्यूबल स्ट्रक्चर जो पीछे से आगे जाता है, दैट यू कैन लाइगेट बाय मिस्टेक, यू नो, एंड यू विल से सर यूरेटर, and then they'll fire you. How can you ligate the ureter? Arey bhai, you cannot ligate the ureter. Why you cannot ligate the ureter? Because ureter is not in the abdomen. Ureter is behind the abdomen. It is a retroperitoneal structure. So they will ask you this. They'll try to elicit this mistake out of you. And when they say ureter, they'll start firing you because you don't know your anatomy well. So that is a favorite Viva question. Can you ligate the ureter? Please never say. In fact, it happened with one of my, I remember long back when I was in my MBBS, they asked me in a table Viva. It was not the final exam. We used to have a send-up exam pre-final. And my professor asked me. So he kept giving me that hint. Can you ligate that one tubal structure is there, one tubal structure going from the side coming? I said, sir, I will not ligate the ureter. And he started smiling because he knew that somebody who had given the exam had already told me before. So yes, I said, sir, I will not ligate the ureter. So please, do not say that you ligate the ureter. Also, don't say that you ligate the uterine artery. Uterine artery is not freely hanging, okay? Uterine artery is next to the uterus and you have to dissect out the round ligament, uterine artery from the leaves of the broad ligament. You cannot ligate the uterine artery also. So don't say artery, don't say ureter. What you can easily say and pass the exam, round ligament and small bowel. These are the commonly ligated wrong structures. So enough about these wrong ligated structures. Let's move on and see some other things. Why it's not... Yeah. So ureter cannot be ligated even by mistake because they are retroperitoneal structures. Yes, just a completion of the notes. And uterine artery also cannot be ligated. I told you these two. Please, those of you are seeing late, please remember this cannot be ligated. All right. Chalo. So failure of rate of tubectomy is more than vasectomy. That's why vasectomy is the more preferred method when we do permanent sterilization. Tubectomy, as you know, a lot of women have died in tubectomy in our country. Yes, unfortunate truth, but it has happened. Vasectomy, I have not heard. Yes, side effects to any injections like lignocaine given for a local block can cause anaphylactic reaction and the patient can go into a shock and the hypersensitive reaction and can die. But I have not seen that happening. In touch wood, I don't want to see that in my life. We have done quite a few vasectomies in our life, but tubectomies, a lot of people have lost their lives also. So yes, it's a much safer surgery to do a vasectomy. So failure rate is less than tubectomies, and non-scalpel vasectomy can be done. We stabilize the vas with the ring forceps, pull out, and a sharp artery forceps is used to dissect it. I'll show you the instrument. It's easier for the understanding. A T bandage is tied. Surgeons will teach you how to put a T bandage for the scrotal support and avoid lifting heavy weights for 5 days, we say, because there is some congestion in the scrotum because of this surgery. So yes, this is the instrument. So there is a sharp dissecting forceps. Yes, that's what I want to tell you. A sharp dissecting forceps. This sharp dissecting forceps, can you see the tip of this one? This is by, this is of course which commercially available kits. So in this, you use this sharp instrument to make a stab wound in the scrotum. So we first obviously give the local anesthesia, and at the base of the scrotum, somewhere here, we make the incision. So with that one incision, just one stab incision, because if you tell a man that I'm going to make a cut in the scrotum and go and ligate your vas, and men are very sensitive about their privates, and they don't want any surgery to be happening. Okay, any small knock on the testis also is very painful. So what happens that men are not very happy getting the surgery done. So we tell them, okay, see, I'm not doing any cut. I'm just giving you local anesthesia. Under anesthesia, I'll just make a small incision, and that is not even going to be seen after the surgery is over. So that's how men get convinced, and we give them more money than we give it to women. Okay, the money given by the government is much higher. In fact, if a layman, a man who just walks in and says, I want a vasectomy, we give them 1100. The motivator, we give 200 rupees more. But the government servants, if they come, suppose there's a, I think I'm correct, PSM people again, if they are listening, they can correct me if I'm wrong. But there is a one increment in the salary given by the government. That if suppose there's a lower division clerk who comes to me after having 2 children, he comes to me and says, sir, I want a vasectomy. So if I do a vasectomy this month, he gets the senior division clerk, the higher salary for 1 month, one incentive. Like if a major gets it done, he gets a colonel salary like that, or a lower soldier, a soldier gets it, he gets a Nike's salary for a month. That one increment is given. So government servants will generally get this done easily. So you make a small incision with this, a stab wound, you make a small incision, open, go and hold this vas, take out, go and hold this vas and take out. So how do you stabilize it? You stabilize it with a ring forceps. The ring forceps is used to stabilize the vas, and then we ligate the vas. And when you do the ligation, I'll come to your questions. I've gone into vasectomy. I'll come to your questions. So when you're doing this ligation of the vas, suppose you do the ligation of the vas somewhere here. You've done the vasectomy here. So the part which is distilled, see this part will have sperms. Yes, this part will have sperms for almost 3 months. Some sperms will be there for almost 3 months distilled to the ligature. So that's why we tell them that even after I do a vasectomy, you're not sterile immediately. You will take 3 months to get sterile. So for the next 3 months, you must take some alternative method of contraception. So post vasectomy, use alternative method for contraception, and that is for 3 months. For 3 months or 20 ejaculates. It takes 3 months for this part distal to it to get emptied, or it takes 20 ejaculates for this part to get emptied. Look, your PSM book says 30 ejaculates, but my Williams Obstetrics says 20 ejaculates. So I will have to quote Williams Obstetrics because that's the book of reference. And if they're asking you in your final MBBS exam, so whichever exam you're writing, please ask your PSM people what they want, and please ask your gynae people what they want to write if you're writing the MBBS exam. Those who are writing the entrance exam, go ahead and write 20, because Williams Obstetrics is the book of reference for anything about contraception and obstetrics. So if that book writes 20, you will have to answer 20 in your exams. Okay. Anyway, they are not going to give a choice between 10, 20, 30, 40. No. Between 20 and 30, they are not going to give a choice, because they also know the doctors who are making the MCQs are seniors. They are all professors of major institutes. So they also know that 2 books give different values. So they don't give both the values together. All right. So yes, 20 or 30, depending on the college where you're working, you can modify. Be smart. All right. This much you can know. All right. Why alternate method is used? I told you, Sudha, that there are sperms in this part. So these sperms can be there every time he has sex for next 3 months, or at least 20 ejaculates. So these sperms can make this man's partner pregnant. So for the next 3 months or 20 ejaculates, whichever gets over earlier, because some people will have sex almost on a daily basis. So the 20 ejaculates get over earlier also. So whichever is earlier, that time is used, is a warning that that time please use some other method of contraception. Mostly they'll use barriers for that time. All right. Then after this 20 ejaculates, 3 months is over, also do a semen analysis. Also do a semen analysis and prove azoospermia. You must do a semen analysis, because if you cut a wrong structure, if you've not done a proper ligation, then the man may still have sperms. So till you do not prove azoospermia, we do not give the certificate. Once he gets the certificate from me that yes, he is azoospermic now, then he approaches the government, and the government gives him that 1100 rupees which is promised. All right. In high focus states like UP and Bihar, those high focus means where the population control is a problem. There we give almost 2000 rupees. But in non-focus states like Kerala and Punjab, non-focus states, we give them 1100 rupees. All right. So semen analysis is also done. So what are the complications seen after you do a vasectomy? Once you do vasectomy, there can be a any surgery. I did not tell you about the tubectomy, same complications there, but there are some peculiar things in vasectomy, so I'm giving you the list. The complications can be hematoma formation in the scrotum, infections can happen, a spermatic cyst can form because you block things, so spermatic cyst can form, and they can be anti-sperm antibody formation. Why can that happen, anti-sperm antibodies? Sudha, please listen to this one. Anti-sperm antibodies happen because there is something called the blood testis barrier. So sperms are never in contact with the blood of the man. Yes, sperms are never in contact. But when you do a surgery, and if there is some bleeding and some ligation or some extensive procedure is done, if the sperms come in contact with the circulation, then the body treats these sperms as foreign antigens and starts making antibodies against these foreign antigens. So eventually, even later, if you do a reanastomosis, they may not be able to have children because of the anti-sperm antibodies which have formed in the body. So the sperms keep getting progressively destroyed because of that. Right. What are the other complications? Yes. In addition to these complications which you see after a vasectomy, what are the other complications? Loss of libido, cannot have sex, loss of strength, cannot lift things, cannot do work, he cannot work in the field anymore, and he's so weak after the vasectomy that he cannot work with the animals, the cattle which he has to use for the plowing of the fields, and he's totally invalid after the vasectomy. All of these complications can happen. Yes, what do you say? So please, none of these complications happen. Okay, I've mentioned them only to criticize the beliefs we have in our society. Yes, vasectomy is hardly done in the villages, hardly done by the people. The laymen will never get it done. Only the educated class, which I mentioned, the government officers and the army and the soldiers and the officers and the IS officers, yes, doctors, they get vasectomies done. People who are uneducated, they're very scared of vasectomies because, sir, how will I have sex? I'll have no strength. You have cut the power supply for me. These are the kind of things they say. So please, they can have sex, they will have an ejaculate, they'll be totally fine. But the sperms will not come out. The seminal vesicle, see, please understand, the semen is not just sperm. Semen, see what is coming here. Can you see this passage? There is this seminal vesicle secretion, there is this prostatic secretions, bulbourethral gland secretions. So all of that will make the semen volume. What is the major component of the semen volume? Seminal vesicle secretion. 70% of semen is the seminal vesicle secretion. So those secretions will keep coming. So please, he will have an ejaculate. He will be able to have erection, everything, but he will not have sperms. The only thing missing is the sperms. So he will have sex, he will be able to do work, and he'll have no deficiency in his performance anywhere in the life. Okay, so that's what about vasectomy is. So yes, that's what I had to tell you today. And contraception is many more things. Contraception, if you actually sit with me, it'll take 8 hours of a class. So let's see what we can do in bits and pieces. But these are the important ones which come in exams, especially the COCPs method of action and the benefits of COCPs and the rare side effects and the tubectomies and the vasectomies. All right. So yes, what are the questions, sir? Why fimbrectomy is not done? Because fimbria is catching the egg, my dear. See, if you understand that when a woman is having ovulation happens, fimbria catches. So that catching of the egg is by the fimbria. So if you do a fimbrectomy, the fimbria is gone. There is no fimbria. So there will be a stump of tube like this. She comes to me after 5 years. Sir, mera to divorce ho gaya. My children have been taken away by the custody has been given to my husband. I anyway love this man, so I'm not getting the custody because I'm the reason of the divorce. So she doesn't get custody. Now she says, can you please reanastomose? What will I do with this tube? There's no fimbria. You need the fimbria to catch the eggs. There's no fimbria in this tube. So what will I do? Where will I reanastomose? So there's no fimbria. You cut the fimbria and throw it off. So that's why fimbrectomy is not done. I'll have to make a new fimbria. That does not work so well. After vasectomy, how many days need for rest? Any surgery, 2 days or 3 days of rest, it's a minor surgery. He can go to work tomorrow. Actually, he can go to work, but he should not be riding a bike, we say, because you know the scrotum is on the tank of the bike, isn't it? And the vibration will cause maybe him to have a swelling or even bleeding for that matter. So we tell, don't ride a bike and don't lift heavy weights. You'll have pain because lifting weights does not cause any problem. But when you lift weights, it is Valsalva maneuver. You know, you do like that, you lift weights. This is endometriosis. This is how endometriosis looks like. When you look at the uterus And the ovaries, I'll show you normal ovaries and videos about them. So this is the uterus here, these are the ovaries here. Both the ovaries are having the chocolate cyst. So we are discussing endometriosis first, and in this you will see this chocolate cyst, and these two ovaries are so heavy in the pouch that they are kissing each other. That's why you see kissing ovaries. Yes, you see kissing ovaries in cases of endometriosis. The ovaries are so heavy and full of endometriotic fluid, which is basically brownish in color, which is menstrual blood basically. So that's why we call them chocolate cysts, which are both sticking to each other, kissing ovaries. See this? Yes. Look at the the uh, adhesions here. I want you to concentrate on the adhesions and look at the tubes here. Look at the tube here. See, the tube is so badly kinked. So if a tube is so badly kinked, it is like this. It is supposed to pick up an egg. So if the tube is kinked somewhere behind like that, you saw the angulation in that tube. If the tube is so badly kinked, you think it is going to catch the egg properly? See, the egg is supposed to be here. Sorry. See, the egg is supposed to come out from the ovary and the tube is supposed to pick it up. Ovulation and pick up. But the tube is so badly kinked. How do you think it's going to pick up an egg? That's why infertility in endometriosis. So yes, let us see about endometriosis. Endometriosis basically is ectopic endometrium, and the main etiology is the Sampson's implantation theory of retrograde menstruation. So if you see the uterus and the fallopian tube here, so what happens every month? Every month the woman menstruates and the blood has to come out from the cervix. So when the uterus is trying to push this blood out by contractions, I'm trying to show you my hand like the uterus and the cavity and this part is the cavity of the uterus. So when the blood sheds because of the progesterone withdrawal, the shedding of the endometrium has happened. Now uterus will try to push this blood out. Then only the cervix will open. The contraction of the uterus will open the cervix. Now those contractions will take some time to open the cervix. Before that happens, some blood will go ulta, retrograde, and deposit over the ovary. Yes, and then it will deposit over the bowel. It will deposit over the ligaments. So these deposits, all these deposits, these are the deposits of endometrial glands. The endometrial blood is not RBCs alone, isn't it? It has got endometrial glands. So those glands go out and they get implanted in the pouch of Douglas, on the ovaries, bowel, and the ligaments. Now what happens next month? This month the implantation happened. Now next month what happens? She's going to menstruate again. So let's see. She's going to proliferate. Now she's going to proliferate every month. Next month when she proliferates here, she's going to proliferate here also. She's going to make the endometrium secretory here. The same endometrium which was here in the ligament will become secretory. This will have shedding and this will also have shedding. But this has a place to go out and cause menstruation. But this has no place to go out. So this becomes a bigger and a bigger deposit. So this on the ligaments or on the bowel surface, on the tubal surface, on the on the surface of the ovary, all of these places, these deposits go on collecting more and more endometrial secretions. That is basically the endometrial blood. So that is what is going to cause a lot of pain also to her. So that is what I showed you just now. The first thing I showed you was the look of the endometriosis. So that's how it happens. The implantation of these glands outside the uterus because of retrograde menstruation by the Sampson's theory. All right. And then these places all these places will become ectopic uterine, ectopic uteruses. Yes, they'll become ectopic uterus. So that's why she's not only menstruating here, she's menstruating in all these deposits also. That is what is endometriosis. Very painful condition and also causes severe dysmenorrhea, causes infertility. It's a big problem. All right. Most confusing part is endometriosis and endometrial cancer. Please give clear concept. There's nothing to get confused about this. If you have to understand between endometriosis and endometrial cancer, these are totally outright different. It is like, what is the difference between oral cavity cancer and rectal cancer? That kind of question you've asked me. So good you asked me. This is the place. Please, endometrial cancer is in the endometrium. ectopic endometrium. Endometrium outside the uterus is endometriosis. That's all. Endometriosis कोई कैंसर नहीं है. एंडोमेट्रियोसिस में कोई कैंसर नहीं है. तो जो डाउट आता है जरूर पूछो यार. हमेशा याद रखो कि never a doubt is bad, because if you have a doubt, it will stay till the exam and you will get into a problem. So very good. Understand, endometrial cancer is cancer of the uterine cavity. We are talking about that in somewhat more detail later when we discuss about C cervix and C endometrium in another session of array. Right now we are just discussing endometriosis. So endometriosis is ectopic endometrium. Endometrial glands outside the uterus. Bas itna yaad rakho. And they start behaving, all these places start behaving like a uterus. To understand that, and then things become easier for us. So endometrium also goes through these tubes, retrograde, all that I told you just now. So now let's see, 70% to 90% all women have retrograde menstruation. You know what? That when we discuss about this retrograde menstruation, which is the cause, the Samson's theory, which is the cause of the endometriosis. You know how many women have this blood going ulta? How many women in this world have this retrograde menstruation? Almost 90% women have this blood going ulta and getting deposited in this pouch of Douglas or on the ovary. So 90% women have endometriosis. No, the blood goes retrograde and it deposits in all these places. But in a few women who have more estrogens, they will make these areas grow in size and become endometriosis. Look, estrogen and progesterone in the body, it is present not only in the ovary and not only in the uterus. Estrogen and progesterone, which is coming from, I'll make another diagram for you to understand this. Ovary. Every month the ovary is making a follicle. Follicle is first making estrogen, then making progesterone. You know that. E and P. E plus P. It is coming from the ovary. Now this doesn't go straight to the uterus like this. No, it doesn't do like that. The estrogen progesterone from the ovary goes into the circulation. So from the circulation all over the body, the estrogen progesterone is present. It comes and acts onto the uterus. Now that estrogen progesterone will also act all over the body. And in the body, there are glands of endometrium outside the uterus. So these places also will be acted upon by the estrogen and progesterone. That's what is endometriosis. The blood goes ulta, glands get deposited, and in these places they start to grow. That is what is endometriosis. Now, how many women have this blood going ulta, retrograde? It is there in 90% women in the world. But not 90% women have endometriosis. Only 10% women in the world have endometriosis. Those women who have high amount of estrogens, they will proliferate these deposits, and when they grow they become endometriosis. Yes, those 10% women who have high estrogen and poor immunity. Two lines: high estrogen, poor immunity. High estrogen, poor immunity. Remember that. High estrogen will proliferate these deposits. Poor immunity cannot clear these deposits. That is what is the basis of endometriosis, right? So we are talking about that only, that 70 to 90% all women have retrograde menstruation, but 10% of women who have poor immunity and increased estrogenicity. Remember these two words, the punchlines: poor immunity and increased estrogenicity, that is increased estrogen in the body. So poor immunity does not clear these deposits which have happened, and poor immunity does not clear these deposits, and increased estrogen will proliferate these deposits more. All right, so 10% women have endometriosis. Okay. Look, can we just do the adenomyosis part a little bit later? We are doing endometriosis right now. A lot of people don't know this first. Okay. So adenomyosis is something else. First, you understand this. So when we have this endometriosis, it's basically, we'll quickly go through the basics and then I'll take your doubts. Okay, we'll do that. We'll go through the basics. That's what we have to do first. So we are not going to do a detailed class. We are going to prepare you for the exam. So what you have to write in the exam, what is coming in the vivas, all that we have to do. And spotters will come in endometriosis. Chocolate cyst pictures will come. They'll have a ovary with a cut section showing endometriosis. All that will be there. Okay. So sites of presentation, most common site is the ovary, and the second most common site is the pouch of Douglas and peritoneal surface of abdominal organs. Now, deep endometriosis, lesion which is at least 5 millimeter beneath the peritoneum. That deep endometriosis is the reason why there is so much of pain. A lot of women have deep endometriosis. The lesion which is sitting over the bowel, suppose it is penetrating through the rectum and going into the rectal lining. So she bleeds in the uterus 5 days a month. She bleeds through the rectum also 5 days a month because of deep endometriosis. This question came in MCI exam just now, 17th, 1 week back. Yes, exactly last week on Saturday this exam question came. What is deep endometriosis? It is already there in your app. Okay. So yes, deep endometriosis is a lesion which is 5 millimeter deeper into the peritoneal surface, and it can present as nodule in the cul-de-sac, that is the pouch of Douglas known as cul-de-sac, rectosigmoid, and even the bladder, this deep endometriosis. Then rare cytodeposits, these deposits can be there in the lung also. Yes, the endometrial glands can go through the uterine circulation, through the veins. The endometrial glands can happen and find the way through the veins into the lung and deposit in the lung. So she menstruates 5 days. She menstruates 5 days through the uterus, but that time when she is menstruating, there is a gland in the lung also, which is endometrial gland. So she proliferates and secretes in the lung also. The day there is shedding in the uterus, there is shedding in the lung. She bleeds in the uterus, she bleeds in the lung. 5 days a month, she bleeds through in the bronchus, and she will have hemoptysis. She may have a deposit on the nose. So 5 days in a month, she'll have epistaxis. 5 days in a month, she may even have subconjunctival hemorrhage. So these are the places: lung, eye, nose, and intestines, sometimes even in nipples. So these are the places where there could be this implantation of glands outside the uterus, apart from the regular places like the bowel and the pouch of Douglas and the ovary. Apart from that also, there might be some areas like this where implantations can happen. So these implantations which can happen, these will behave like uterus 5 days a month. These are known as the vicarious menstruation. This is known as the vicarious, excuse me, vicarious menstruation. Now, sometimes these deposits can be found on the scars also, scars of the cesarean section, the abdominal scar of the cesarean, not the uterine scar, abdominal scar of the cesarean section. It may be there in the episiotomies also. So, scar endometriosis, cesarean section scar, and the episiotomy. There also you can see this endometriosis. So basically, what are the color of the deposits? I'll be showing you a lot of pictures, but remember, the first thing which I showed you in the lecture was the video of endometriosis. So all those deposits, what do they look like? That is what is the pathology. So they look like powder burn lesions. What do you mean by powder burn lesions? Gunpowder. Gunpowder, when it gets burned. You see the matchsticks in your house, when you burn them, the tip is brown. When you burn it, it is bluish blackish in color. So that is the powder burn lesion. So powder burn lesions or blue spots, we call them. Powder means gunpowder, okay, not just talcum powder, it is gunpowder. And chocolate cyst of the ovary, that is within the ovarian endometriosis, there is chocolate colored fluid, and this uh, body will try to heal these deposits which are present. The body will try to heal them. Some healing will be there, although it is not as perfect as other women. So that healing with adhesions, now that is also a very big problem of the endometriosis, because these adhesions, I was trying to show you in the beginning of the chapter that the ovary which is supposed to be under the fimbria, the ovary is stuck behind somewhere here because of the adhesions. So there is altering of the tubo-ovarian relations, and adhesions can also cause a lot of pain because bowel may get stuck somewhere, and the the bowel movements also could be getting inhibited because there is extensive adhesion sometimes. So adhesions are a cause of that chronic pelvic pain in endometriosis. I've shown you those adhesions the first thing in the video. All right. So yes, let us see this normal pelvic anatomy first. I'll just try to help you with these videos now for you to understand. But before that, I want to see your doubts, because otherwise you will not understand. Endometriosis and adenomyosis, will come to it. Rishikaran, hi, how are you? Dadu, all of that is done. Yes, you are. They are just, the team is just finalizing the video, so don't worry about that. March 5th se pehle you'll be able to have all the videos. By the time, the videos which are there, if you see them, you'll already pass your exams. Don't worry, Dadu. Okay, can we just stick to the topic now, guys, everybody? So yes, this is the normal pelvic anatomy I'm showing you here. Normal pelvic anatomy first. Dadu, pay attention here. So this is the round ovarian ligament with the ovary, fallopian tube. This is the round ligament going into the deep inguinal ring. Lovely deep inguinal ring you can see here. So this is the normal pelvic anatomy. Now let us see a endometriotic cyst and tubal adhesion. See, this is the uterus, that is the round ligament there. The tube you're not able to see at all. There are so many. The round ligament is shortened because of adhesions. This round ligament is also shortened because of adhesions. Now can you see the right tube, the left tube? There are so many adhesions. See, barely you're able to see the tube. I am not able to see the tube properly at all. Look at this cyst. This is the ovarian cyst here on the left side, which has totally destroyed the anatomy here. See here the tube I have to take out from the adhesions. Can you see this? It took me almost 2 hours to correct the anatomy of this patient. This was around 2 years back, this video. So can you see the tube is in such adhesions? Can you see this tube here and see these adhesions? That is all endometriosis. And look at this ovarian cyst here. That is the other one. So that cyst I'll show you now. Now these are the adhesions again. The endometriosis causing all these adhesions. And this is the ureter in the adhesion. See the peristalsis of the ureter I'm trying to show you here. So look at this tube here. This tube which was supposed to be on the ovary. This tube is somewhere in the side in the pelvis. This tube, that's what I was trying to show you here. See this tube. This tube is not over the ovary. This tube is supposed to be on the ovary and pick up the eggs. Now tube is somewhere in adhesions here. That's why infertility is also a problem. Now these are the kissing ovaries. This video I had showed you in the introduction to this chapter. And look at these adhesions. Look at the king tube, altered tube over relations. So I'm in the middle of the surgery. I'm just making a video for my students so that they can understand what is the severity of endometriosis. Now this I'm trying to show you. I'm opening this one ovarian cyst I've taken out from the left ovary. See, I've done laparoscopic surgery, so all that it looking black to you because of me having done the cautery. Now look at this side. I want to show you the chocolate pouring out of the right ovary. Can you see that? Chocolate coming out of the ovary. That is the chocolate cyst. Of course, it will bleed when you're doing the surgery. So along with the chocolate, you're also seeing some strawberry forming, isn't it? Strawberry syrup also you're seeing. But yes, classically we say chocolate cyst of the ovary. Now see this, that cyst when I showed you, I'm bursting it to show you what is happening here. Yes? Yeah. The chocolate fluid. Of course, when you do the draining of the chocolate fluid, after that you have to take out the cyst wall. Now this is what I want to understand here with this practical video, that when you're doing this treatment of endometriosis, basically endometriosis happens to young women. You cannot remove the ovary. So I have decompressed the cyst. You see this again. I've decompressed the cyst. See, the cyst is getting decompressed. I'm taking out the chocolate fluid. But I have to save the ovary. She's only 25. So she needs the ovary for her menstrual function and for having pregnancy. So that is the crux of endometriosis. That it is because of high estrogen she's having this. She's going to have this cyst. And when I take out the cyst, I leave the ovary behind because she needs the ovary for a normal estrogen. But she has the tendency of endometriosis. She is going to make a cyst again. Recurrence in endometriosis is the biggest nuisance. So what is the practical aspect of this chapter? The recurrence of endometriosis. That's what you have to understand. Endometriosis can go on recurring till the woman is having menstruation, because it is retrograde menstruation which makes deposits, and these deposits you are taking out the menstrual blood to give her pain relief because the ovary is so big and cystic. You're taking out the menstrual blood. You will take out the cyst wall. After 6 months or 1 year later, she'll make another new cyst. Again, you will take out only the cyst. So that's what is endometriosis. It has a lot of recurrence till the time she is 50 and menopausal. Ultimately, menopause is the final treatment. Till then, she comes to me at 25 and she's here with me till 50 years of age. For 25 years, she'll be my patient. But yes, we can give her a normal life with surgical treatment and medical treatment. She can have a normal life. But she has to come and show me at least once a year. That's what is endometriosis. The recurrence is the biggest problem. To understand this topic, very interesting topic, condition which is there in 10% of women. So many young girls have endometriosis. and you have to tell them that I cannot remove your ovaries. Somewhere I was hearing treatment was given by some I saw some students showing me a lot of sources where the treatment of endometriosis has been given for a 35-year-old woman to do a hysterectomy. Arey nahi yaar, hysterectomy won't be enough. The ovary is having the estrogen formation. So you have to do oophorectomy also. And at 35, if you do oophorectomy and hysterectomy, the woman will be menopausal and have all the side effects of menopause at 35 years itself. So hysterectomy is not the answer in endometriosis. Please understand. This surgery here itself, you understand, we will try to remove the disease but not the ovaries. You have to give her a normal life till 50 years. So this is what is endometriosis, right guys? So do they always need surgery? No. Surgery is not the every time management, but it is mostly the primary management for getting my diagnosis done. We are coming to that part, okay? And LADES, I'm not talking about that, okay? Tajik Khatun, Tajik Khatun, okay? Please teach in English. ठीक है, Shubham Made, all right? So we will try to incorporate all the languages. Okay, so see the cyst, I'm taking out only the fluid and the cyst wall, but I'm not taking out the ovary. See, I'm saving the ovary. That's what you have to understand. Chalo, now there will be a lot of peritoneal deposits also. The peritoneal, you look, the, oh, yes. See, the omentum is also having all these deposits. See, these brown deposits in the omentum. I'm showing you at the liver. On the liver surface also there are deposits, but I don't think in the video you're able to see. Yeah, there's a deposit here. Right. So because of this, I think you understood the problem a little bit at least, because endometriosis is something you read a lot of theory, but till you see all these videos, one of these days, I don't know where you are, if you're interns and if you are medicos, if you're coming to Delhi, just give me a call and you can come to my hospital. If I'm doing the surgery, you're most welcome to come and see. So yes, symptoms are chronic pain, acute monthly exacerbation, present as severe congestive dysmenorrhea and dyspareunia. Now, dyspareunia is painful sex, and this is classically deep dyspareunia. Deep dyspareunia. That is, one is penetration dyspareunia, that is while starting sex, while insertion, there is pain. That is because basically some women have vaginitis. But what is deep dyspareunia? Intercourse is established and the uterus and the cervix and the ligaments move with sex, and those ligaments and the uterus has endometriotic deposits. So that's why it's extremely painful intercourse. Deep dyspareunia and menorrhagia. So dysmenorrhea of the congestive type, and then dyspareunia and menorrhagia. Now infertility, I already told you, I gave you enough hints. Now we are just writing down altered tube-ovum relation. The ovary and the tube are not together, and there is decreased frequency of intercourse because of the dyspareunia and poor ovulation. You saw the ovaries condition, poor ovulation, poor oocyte quality. So embryotoxic endometrial deposits. These deposits which are there, first of all, they'll make bad quality oocytes. If at all an embryo forms, that embryo will be affected by these by this endometriotic deposits. So poor quality embryos, reduce implantation and increase risk of abortion. All of these will contribute to the infertility in this woman. And the best diagnosis can be done by laparoscopy, but other things which will help us, a race CA125 will help us in understanding, because it is not always diagnostic, but because CA125 increases also in CA ovary, but a high CA125 gives us an indication that she could be having endometriosis. Ultrasound is generally the best initial investigation to see that there is an ovarian cyst and there is, let's say, sometimes a hematosalpinx. All of that you can see. Best initial workup, but not the overall best. Initially, it is a good thing to do, and you can see in the ultrasound, yes, this is the transvaginal ultrasound. I had already made this, the probe, the ultrasound probe is here, the TVS probe. This is the probe which is there and is showing us a view, and here you see the chocolate cyst. So this is what is known as the ground glass. This is what is known as the ground glass appearing cyst. Yes, ground glass. Now, what happens? Ground glass. You must be seeing a lot of glass panes around all of you. Through the glass pane, you can see outside of your rooms. But there are some glass panes in the offices. You can see the glass, but they are foggy. You cannot see through them. You can see that vaguely somebody is walking. You can see the shadow, but you cannot see who is walking. That is what is a ground glass. So this is that ground glass appearance. Clear cyst, something like this will be this black color you're seeing, the clear cyst will be like that. But when there is blood inside the cyst, that is what is a chocolate cyst. It is a ground glass cyst. All right. So on the MRI, also you can get a very good imaging. So MRI is the best imaging. Always remember, in radiology, nowadays we don't say radiology, we say imaging, department of imaging, because radiology में क्या है यार, अगर आप अल्ट्रासाउंड करते तो उसमें भी इमेज है, और CT scan, MRI सब में imaging है, isn't it? So this is best imaging is MRI. In gynae generally we say MRI better than CT. Mostly we are happy with MRI, not as a absolute rule, but mostly what I say that MRI is the better investigation in radiology for gynae. So MRI. So that also will tell me, but the laparoscopy is the gold standard. Laparoscopy is the gold standard of diagnosing endometriosis, and this is what you have to write in your exams and even in your NEET, PG and INICT exams. So ideally what we say, you do the laparoscopy. I've shown you many laparoscopy videos. Do the laparoscopy, and with the laparoscopy you see this cyst and the lesion. Then the cyst you're treating, before that cyst which you take out, you send it for the histopathology. So laparoscopy and histological confirmation. Actually this is basically histopathological examination, the biopsy of the lesion. The histopathological confirmation is done. So laparoscopy and histopathology is even better than simply laparoscopy. Okay, I said laparoscopy and histopathology, that is laparoscopy and biopsy, is better than simple laparoscopy. So this is what I've shown you earlier also. Let's move on. So surgical treatment we've already discussed. I'm just now enumerating that. Chocolate cyst, you do a cystectomy. Adhesions, you do a adhesiolysis. And powder-burn lesions, those small lesions. Now those lesions you cannot, there might be 100 such lesions. You cannot cut 100 lesions on the bowel or on the uterus or on the the diaphragmatic surface. You cannot cut at 100 places or 50 places, but those places you can burn. So that is what is known as the fulguration. Fulguration of these lesions we can do. When we do the fulguration, we can do the fulguration by laser methods and by the thermal method. Laser and thermal methods, you can do that. Okay, now post surgery, I told you that she may come back to you with within 6 months to 1 year with another cyst and the recurrence of the problems, because she's a young lady. 25 to 35 is the peak age of endometriosis occurring, young woman. All right, so she may have endometriosis as early as 1 year or 6 months also. So what do? You have to make sure that she does not form these things again. So what is the reason she is forming endometriosis? Because of the high estrogen. So you can reduce the estrogen amount, and that is the medical management of endometriosis. So surgical management you understood very easily. Cyst है तो काट दो, adhesion है तो निकाल दो, और अगर powder burn lesion है तो जला दो. This you understand very well. But surgery is only the initial part. The biggest treatment of endometriosis is to maintain the state of normal ovaries and normal uterus with your medical treatment. And in this, you have to suppress the estrogens so that you will have lesser menstruation and lesser endometriosis. And lesser estrogen means all these deposits in the pouch, in the ovary, in the bowel surface, all these deposits get lesser estrogen to proliferate. Sometimes we don't say lesser estrogen, we make her no estrogen kind of a patient. We reduce her estrogen so much, there is hardly any estrogen in the body, so she gets even much more better with the endometriosis. That is the medical treatment. So that is what is coming next. All right, guys, there's 60 to 70% recurrence. So medical management is basically to reduce the estrogens. Where is that? Yes, medical management is basically to reduce the estrogens. So we'll come to that, but let us first talk about the pain relief, medical management. NSAID is for the pain. To reduce the pain, we can give combined oral contraceptive pills will make the cycle anovulatory. So it reduces pain by anovulation, because anovulatory cycle is painless. First chapter, guys, menstrual physiology, first chapter. Please see the app. Always I remember that is the core of gynecology. The first chapter, menstrual physiology 1, menstrual physiology 2. All right. So combined oral contraceptive pills will reduce pain and they will also reduce the estrogen. Okay. So the disease also limited. So annual cycles are painless and also it limits the estrogen because it has got, the patient has lesser estrogen in the body because of the OC pills. All right. Right. So that is the basis, that you reduce the estrogen as the medical management. So I have told you only one drug so far. One is the painkiller, other one is the COCP. Giving COCPs on a 21-day regime, or sometimes we give continuous COCPs for 4 months and then only give a gap. So she gets periods once in 3 months, once in 4 months, like that also we do. But COCPs is that one very good drug which we can help the girls with. But what are the better methods, even better than COCPs, to reduce the estrogen? I'm just giving you an outline of treatment, guys. We are not going into detail. Actually, this is the basic outline of endometriosis. So yes, the other management is to oppose the action of estrogen. How do you oppose the action of estrogen? Give progesterone. So progesterone causes secretion of the endometrium and stabilization of the endometrium. So when you give this progesterone for a long time, it causes the atrophy of the endometrium. Continuous use of progesterone causes atrophy. The endometrium won't grow at all. So when the endometrium doesn't grow at all, because there is so much of secretion that there is no proliferation possible, constantly give progesterone. So endometrium becomes atrophy. So the punchline of the evening, remember guys, this is that punchline of the evening, atrophy of the endometrium in endometriosis. The word you're learning today with me, endometriosis. You need to reduce the estrogens. COCPs reduce estrogen, but better drugs are there like progesterone, androgens, GnRH analogs. They will stop the estrogen function altogether. So when there is no estrogen function, there is obviously no glands growing. When there are no glands growing, that means atrophy of the endometrium. So where all does the atrophy happen? Atrophy happens not only just in the uterus. See, the endometrium will be atrophic. There is no gland growing. I'm just making a lining. There is no growth of the gland. Okay. And the pouch of Douglas, these glands will become atrophic. Ovarian glands, they will become atrophic. Wherever there is endometrial glands, they need estrogen every month to proliferate. Endometriosis needs estrogen to proliferate. You make them lesser estrogenic places by COCPs or inhibit the action altogether by giving high dose of progesterones. Atrophy will happen. Again, I'll tell you atrophy in the next slides. Okay. So progesterone causes atrophy of the endometrium. So the method of giving progesterone is by the depot-medroxyprogesterone estate, that DMPA, which you heard in the chapter of contraception also. So DMPA 150 milligrams once in 3 months you can give, or you can give tablets of Dynogest. That is this new exciting drug which is now used. A lot of people don't like the injections given on a 3-monthly basis. You can give Dynogest. Both of these will cause atrophy of the endometrium. Can estrogen cause problem? We are coming to that, my friend. Yes, the whole chapter is about that. So hold your guns, listen to me. Okay. Momin Liaquat, welcome here. Speak in Hindi. Yadav, Priyanshu, look guys, I'm so sorry. The exam is going to come in English यार. तो मैं हिंदी बोल सकता हूँ, मैं चाहता हूँ कि आप हिंदी सुने, बट यहाँ पे बहुत सारे मेरे दोस्त साउथ के भी हैं, उनको फिर तमिल चाहिए होगी, किसी को बंगाली चाहिए होगी, तो कि আমি বাংলা বলুন কি আপনার কি কিনতে চান আপনি how much do you want guys? So we have to speak in English guys, so that is the medium of instruction. ठीक है, कुछ समझ में नहीं आएगा तो पूछ लीजिए मुझसे, मैं हिंदी में जो पार्ट समझ में नहीं आया मैं हिंदी में एक्सप्लेन कर दूंगा. ठीक है, चले आगे बढ़ते हैं. तो डायनोजेस्ट प्रोजेस्टेरोन देने से एट्रोफी हो जाता है. और आगे बढ़ते हैं. अब हमें ईस्ट्रोजन, वी आर ट्राइंग टू रिड्यूस द ईस्ट्रोजन, ईस्ट्रोजन कम करना है. तो ईस्ट्रोजन कम करने के लिए, एंटी ईस्ट्रोजन एक्शन करने के लिए हमने बताया यू कैन रिड्यूस बाय COCPs, यू कैन रिड्यूस बाय द प्रोजेस्टेरोन्स एंड यू कैन गिव एंड्रोजन्स. Androgens are anti-estrogenic, so they cause much faster atrophy. Androgen have an anti-estrogenic action, so that's why when you give danazole will be, it's a tablet which is having an androgenic action. It has got a high androgen action and it makes a low estrogen environment. It suppresses the GnRH and the gonadotropin secretion, so it does not allow the ovulation also to happen. Ovulation is the one which is making estrogen and progesterone. All right, and it directly inhibits steroidogenesis, so also causes increased clearance of estradiol and progesterone. So this mode of action of danazole keeps coming in your exams. How does danazole help? It basically is a anti-estrogen kind of action because it's an androgen. And how does this act? It reduces the androgenic environment by the suppression of the estrogen. It reduces the estrogenic action by increasing the androgenic action and also suppression of the steroidogenesis. Okay, but yes, androgens will have side effects. So you can give it for a year or so, maybe 2 years, but by the end of this first year, 1.5 years, she will have the side effects of hirsutism. And the hirsutism, you know, is the male type of baldness, facial hair, and acne. But they can be worse. Hirsutism is male pattern baldness in a lady, facial hair, acne. But what is virilization? Virilization is hoarseness of voice. The voice of the girl starts sounding like a boy, hoarse voice, and breast atrophy and clitomegaly. Now, why did I make them separate headings? Guys, concentrate. Why did I make them separate headings? Because virilization is irreversible. Yes, virilization is irreversible. If you stop androgens, if you stop the androgens, then the patient will have reversal of the hirsutism. The acne will clear up. Okay, the acne will clear up. The facial coarseness will clear up. But if you stop the danazol, the virilization won't get treated. Virilization is lifelong. Yes, these are permanent. It is irreversible. That is what is the difference between hirsutism and virilization. So when there is virilization, you cannot reverse it. So that's why we always ask you, what are the indications of stopping the treatment by danazol? The first sign of stopping treatment by danazol is the hoarseness of voice. MCQ. That stop the treatment by danazol if the woman starts having hoarseness, because next she's going to have a clitomegaly. I've seen a girl with a clitomegaly. It was so bad, not because of this. I mean, she had some androgenic tumors. It was like a small penis in a lady, and it was a 2 centimeter long clitoris. So that's why clitomegaly can be an extremely worrisome condition for a lady. And if you stop the androgens, the clitomegaly does not shrink back. Yes, it will persist. The clitomegaly will persist for life. You will have to do surgical management. So that is why we must understand the difference between hirsutism and virilization. That's why we are impressing upon the outright basics which my students from PW should understand, right? So next, what we can give the GnRH analogues. Now GnRH analogues, before giving that, मैं समझाना चाहता हूं कि GnRH नॉर्मली क्यों कैसे काम करता है और GnRH एनालॉग्स क्या होते हैं. तो GnRH क्या होता है? ये एक पल्सेटाइल रिलीज है. आपको पता है कि एक पल्सेटाइल रिलीज होता है विच इज वंस इन 90 मिनट्स. और ये GnRH गोनाडोट्रोपिन रिलीजिंग हार्मोन पिट्यूटरी पे एक्ट करेगा और वो गोनाडोट्रोपिन्स को निकालेगा. गोनाडोट्रोपिन्स मतलब FSH and LH. So gonadotropin releasing hormone, pituitary, FSH, LH, ovary, makes a follicle estrogen, ruptures the follicle, the same follicle becomes corpuscular, makes the progesterone. So estrogen and progesterone in the ovary because of the stimulation of the pituitary by the GnRH. ये हमारा normal menstrual cycle है. ये मैंने हमेशा बोला है, do not come to any hormonal chapter without reading the menstrual physiology chapter. That is the core of my classes. Once you understand those 2 chapters which are there, you've already been given the notes on the online sources. So please read the menstrual physiology chapter. That is extremely important. So once you understand that, now GnRH analogues क्या होता है? GnRH analogues. Analogues means drugs which are like GnRH. So like GnRH matlab GnRH is stimulating the pituitary. Like GnRH will also stimulate the pituitary. Correct? Analogues are the same drugs like GnRH. They will also stimulate the pituitary. ध्यान दीजिए यहाँ पे. Please do not get distracted. Any one of you thinking of anything else. If you not understood the chapter endometriosis, ठीक है. If you've joined just now, understand GnRH analogues, especially my MBBS students. The interns and the post-interns, PGs have understood this part. But my MBBS students are the major concentration for this class. And understand that GnRH analogues are the same as the native GnRH in the body. GnRH analogues, same action hai. So same action if you do the same action like the GnRH, the same action is the GnRH analogues. So don't you think you'll stimulate the pituitary too much? And the pituitary will make more FSH, and more FSH will make more ovarian follicles and more estrogen? Yes, GnRH analogues will do that only, correct? So we change the method of giving. Remember, the drug is given in a different manner. Normally, the GnRH is pulsatile once in 90 minutes, but we give continuous GnRH analogues. So, when you give this GnRH analogues continuously in a continuous infusion or in a depot form, we give a high dose of GnRH analogues into the muscle of the lady, and it works for 1 month. Some injections work for 3 months. So continuously you give this in a daily inhalation form or an injection form or a depot form you give. Either way you're constantly giving GnRH, not in a pulsatile form. देखो पिट्यूटरी को आदत होती है कि once in 90 minutes में उसे स्टिमुलेशन मिलता है, तो 90 minutes में एक बार वो काम करती पिट्यूटरी. दैट इज व्हाट इज द बेसिस अबाउट द पिट्यूटरी फंक्शन. 90 minutes में एक बार काम करना है मुझे. बट नाउ व्हाट you give it continuous stimulation. Stimulate, 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 and stimulate, stimulate, stimulate. आप उसको ब्रेक ही नहीं दे रहे हो पिट्यूटरी को. पिट्यूटरी बोलेगी भाड़ में जाओ, मैं काम ही नहीं करूंगी. Yes, पिट्यूटरी will say I will not work. You're stimulating me so much, I cannot work so much. I work once in 90 minutes. So yes, ये pituitary, you stimulate it so much that it cannot respond to the stimulus anymore. Pituitary थक जाती है काम करते करते. So when you give it so much of stimulation, it'll try to work up to the stimulation for 1 day or 2 days, and then the pituitary gets suppressed. So yes, this causes something called down regulation. The word, all these receptors get down regulated. They cannot respond to the stimulation anymore. So yes, there is down regulation or desensitization, down regulation of pituitary. So pituitary is now sleeping. And that pituitary which is sleeping, that means there is no FSH and LH. That means the ovary is also sleeping. That means there is no estrogen and no progesterone. That means there is atrophy again. Yes, there is atrophy again. So we cause atrophy by this. Then we had caused atrophy by the androgens. They will also cause atrophy of the endometrium, faster atrophy. Then we discussed about the progesterone. They cause the atrophy. And then we discussed about the estrogens. Estrogens cause the limitation. They cause the limitation of the endometriosis. So medical management, I'm trying to be very repetitive here. Medical management aims at causing limitation of the endometriosis by OCPs, atrophy by progesterones, atrophy by androgens, and atrophy by GnRH analogues. What are the names of the GnRH analogues? Leuprolin, naferlin, goserlin. There are many lins, okay, GnRH analogues. Yes, so all of these will cause the woman to have a good relief in endometriosis. This GnRH analogues is supposed to be the best medical management, of endometriosis. Okay, remember that. So yes, now the problem is, somebody is already asking me, if you suppress the estrogens for a long time, what will happen? So yes, I'm giving GnRH analogues. It's giving me very good results. The patient is fine. It has got atrophy of the endometrium, so she has no pain in the pelvic pain. There is no dyspareunia, and she's having much relief from the disease. But she's also not having periods because there's no estrogen. Okay, I'm saying this is for your treatment. As long as the drug is given, you will have no periods. Correct. But your disease also won't trouble you. So you have to live with that you're not having periods for some time. Okay, sir, you're healing me. Thank you so much. But if you do not give estrogens for more than 6 months, then the bones will miss the estrogens maximum. The bones will miss the estrogen very badly because estrogen is required for the bone formation. Yes. Please see the HRT chapter, all right? The PW, all the app, we have given all these important chapters. Please see the HRT chapter. Estrogen is paramount for the woman. That estrogen is not there for this woman. If you stop the estrogen production for more than 6 months, it can cause osteoporosis. If given for more than 6 months, can cause osteoporosis. osteoporosis. But that does not mean that I will stop my treatment. Very important fundamental here. I know if you give GnRH analogs for more than 6 months, it can cause osteoporosis. But I can continue the treatment with GnRH analogs and give her a little bit estrogen, which is required for the management, for prevention of the osteoporosis. So yes, after 6 months, look, there are many women we give GnRH analogs continuously, 3-4 years we've given. Excuse me. But after 6 months, we give some low dose estrogens to prevent the osteoporosis, and that is what is given by the add-back therapy. That is what is known as the add-back therapy. This is what is the pharmacology question which keeps coming. What is the meaning of add-back therapy when you're giving GnRH analogs? So that estrogen reduction is good for the treatment of endometriosis, bad for the bones. It causes osteoporosis. So continue the GnRH, but give a low dose estrogens. So we can give this Tibolone. Tibolone is a synthetic estrogen. HRT chapter, okay, please see that synthetic estrogen, and it has got a progestation action. Norethistron can also help in the osteoporosis, and conjugate equine estrogens with medroxyprogesterone acetate. Okay, equine estrogens with medroxyprogesterone acetate. We can give these also. So this is what is known as the add-back therapy. Continue giving those drugs, and one of these drugs, generally I give this Tibolone, or I give a low dose of estrogen tablets. We have estrogen tablets like Premarin, low dose of Premarin I will add. Okay, so all these drugs will help the osteoporosis. That's about endometriosis. I actually got very emotional about this chapter because we see so many young girls. Which book? PW, the app of Obs and Gynae. Man, that is the app to read. All right, come on. Which so what about the other hormones which are secreted? So pituitary is not totally suppressed. Good question. I like that question so much, future doctor. The problem is when you give GnRH analogs, that is going to tire out the pituitary. Which part? The gonadotropin releasing hormone agonists, they are going to stimulate the pituitary's FSH and LH making parts. Those parts get so much downregulated. Not the entire pituitary. Yes, you are not suppressing the entire pituitary. So pituitary is it's the master gland. You know about that. So it is going to help in so many other functions. Only LH-FSH production is reduced. Good question. Good. That means you're listening. Good. Chalo aage badhte hain, guys. If you don't have any other questions, which book you're referring to? Again, the PW app is the best book. Yes, you guys are here with me because you are doing the best kind of education with the best teachers. You're trying to understand the basics with us. Outright core basics. That's what we always teach you in our classes. All right, chalo aage badhte hain. To prevent osteoporosis, what is given? Once again, it's there. We're still in that same screen. Sudha, we are in the same screen still. Okay, let's move on, guys. And Sudha, you can see this. Let's get into fibroids. Okay, fibroids or leiomyoma. Here, yours truly, I'm holding a fibroid after a myomectomy. This is one of the 23 fibroids I took out in this patient. Long surgery. This was done during the Corona days. So, in addition to wearing a mask and then wearing a shield and then having another shield in front of me, there were some days, man, doing surgery during the Corona days. And there was no AC. It Corona started in the time of March, April, and it was peak heat summers, and the ACs were put off because the ducts are all connected. So in big hospitals, so if there is a Corona patient you're operating and the aerosols, it was assumed that all of that is going to take the virus all across the hospital. So that's how it was. Anyway, so let's see about fibroids. Now, fibroids, also known as leiomyoma. So when you talk about leiomyoma, you must understand it is the most common tumor of women. Yes, let me just stop this and give you the understanding. What is the most common cancer of women? You always say CA breast. Most common gynecological cancer of women, CA cervix. Correct. But that is cancers, malignancies. When I say tumors, tumors can be benign and malignant. If you see a woman, okay, one woman standing in front of you, the woman top to toe, there are so many bodily organs. They can all have benign tumors and malignant tumors. So tumor, if I say head to toe, all organs included, the commonest tumor in a woman is the fibroid uterus. Okay, commonest tumor in the woman. Malignancy, CA breast, CA ovary, you know very well. Commonest tumor in a woman is a fibroid. 30% women in the world have fibroids. All right. So as many as 30% all women, and it is 2.5 times more likely to happen if a relative has fibroid, and this woman has 2.5 times more chance. It is associated with chromosomal abnormalities also, and it is seen more in nulliparous women, and again it is increased estrogens that is associated with fibroids. So that's the quick revision of the etiology. It is also associated with increased growth factors like the transforming growth factor and the platelet derived growth factor, PDGF rather, platelet derived growth factor, epidermal growth factor, and the vascular endothelial growth factor, right? So fibroids are monoclonal tumors, and these are smooth cell tumors. You'll see these whorls. Can you see, if you just concentrate on this part of the histopathology, can you see there are whorls, circular arrangement of spindle muscles, whorls of smooth muscle cells you see in fibroids, spindle shaped cells, eosinophilic cytoplasm, oval nuclei with a blunt end. The pathology teachers will tell you all of this much better, but I thought I'll just tell you that it's a monoclonal smooth muscle tumor, and these are surrounded by a pseudo capsule. So can you see this uterus, which is the normal muscle here? I'm trying to show you with shading. Now this is the whorls of smooth muscle cells, and this red line is there to show you that it is an encapsulated area here. It's an encapsulated area here. So we say it is an area of smooth muscles, whorl shaped arrangement of smooth muscle fibers. So you can see in the uterus, you will see an area of a fibroid. You can see it easily. Now, here I'm going to take a break and make you understand a few more things. So, concentrate, guys. So, fibroid uterus, the fibroid may be like this, the fibroid may become bigger also like this. Again, in a whorl, circular arrangement, गोलाई में रहता है, whorls of tissue, गोलाई में रहने वाला ऐसे. तो फाइब्रॉइड ऐसे ऐसे भी बढ़ता जाएगा, ठीक है. So, fibroid will be a circular arrangement of smooth muscle fibers. So, fibroid is an irregular enlargement of the uterus. Irregular enlargement of the uterus most of the time. I'll show you many pictures also just now. Irregular enlargement. But there is something called adenomyosis. Adenomyosis is different. Adenomyosis has uniform enlargement of uterus. Wait, I can show that to you immediately now so that we don't keep imagining things. Let's see if I have my... See this, guys. This is the regular enlargement of the uterus here. See, this is adenomyosis. Fibroids, I'll be showing a lot of pictures in this lecture. This is adenomyosis. Now, there are three things now we're discussing together. Okay, so don't get confused. Concentrate. No left, right. Okay, only center. इधर उधर की बातें नहीं करनी. When we're talking about endometriosis, blood going outside the uterus and getting deposited over the ovary, ectopic endometrium in the pouch of Douglas in the ovary. Sometimes the blood goes out from the uterine cavity here. See, this is the compressed cavity, and it goes only into the muscle of the uterus. So there is blood which is ectopic again. Uterus से बाहर glands चले गए. कहाँ गए? Uterine muscle के अंदर. The glands have gone outside the uterine cavity. Now they are within the muscle of the uterus. That is what is known as the adenomyosis. If the glands go out and they are present in the pouch of Douglas, on the ovary, on the bowel, in the diaphragm, endometriosis. Glands go outside the uterus, are present in the muscle of the uterus, adenomyosis. Look, the adenomyosis uterus is uniformly enlarged. This is uniformly enlarged. Okay. And now we're talking about fibroids. Fibroids are nothing to do with ectopic endometrium. Fibroids are smooth muscle tumors. All right. So that is a different etiology. But I'm comparing all of these because you asked me in the beginning of the chapter the difference between that. And endometrial cancer will be in the uterine cavity. Okay. So that some of the time we'll discuss. So abhi I'll get out of this. Back to my lecture. Yes. क्या पूछ क्या रहे हो तुम लोग? मैं वहां पे चले जाता हूँ. All right, same things. Okay, Fahad, thank you. Okay, let's move on. Fibroids are monoclonal tumors, and I told you about this already. Yes, so there will be this irregular enlargement of the uterus in a fibroid. Okay, now let's move on and see what is the morphology of fibroids. A lot of questions are coming on this these days, especially for the NEET exam students. Okay, so what happens? Fibroids will always start in the muscle of the uterus. Basic. Fibroid शुरू कहाँ होता है? हमेशा uterus की muscle में शुरू होगा. So fibroids start in the muscle of the uterus, and that is treated as a foreign body by the uterus. There is a muscle, whirl of smooth muscle here. Now, suppose I'll try to show you with my hand here. Yes, I have a better example. I'll show you with this. Yeah, here. Look, the same thing I'm trying to show you with my hand here. See? Yeah, see, there's a fibroid here in this uterus. Can you see? Just that I'm reproducing here. Can you see this black dot? Yes, it is there. You can see. Now, this uterine muscle does not like this fibroid. Fibroid is treated as a foreign body by the uterus. The uterus goes on contracting. It goes on contracting to push this fibroid away from this uterine muscle. So the fibroid starts in the muscle, in the intramural area. Uterus tries to push it out. So this fibroid gets pushed outside and becomes subserosal. Sometimes it gets pushed inside and it becomes submucosal. That is what is the part of fibroid which is never understood. When we keep reading such big books, we don't understand the outright concept. The concept is fibroid will start here and move on. So it is treated as a foreign body by the uterus. So uterus responds by contracting on the fibroid to push it, and it can be pushed outwards and it can become a subserosal. See, this is a subserosal fibroid. Subserosal. Okay, it may get pushed outwards or it may get pushed inwards and may become a submucosal fibroid here. So subserosal, and this is submucosal fibroid. Okay, so this is what happens to the fibroid. And many other places in between. Concentrate, nothing else. Sit straight, no left, right, only center. Fibroid muscle में शुरू होता है. With the contraction, it can go outside, it can go inside. Inside is called submucosal. Mucosa cavity may coming, it is known as mucosal. Then goes to the serosa surface, subserosal, and many other places in between. That is what is the classification of fibroids which is coming in your exams. So that is the basis of the classification of fibroids. So now I am showing you type 4 पे concentrate करेंगे हमेशा. Type 4 is the most common type, intramuscular fibroid. From there it can move towards the cavity. See, type 3, it is touching the cavity. It can come into the cavity, type 2. It is more in the cavity and less in the muscle, type 1. It is totally in the cavity. See, it is hanging in the cavity by a stalk, type 0. Or it may go outwards. From 4, it may go outwards. See, it has become, from 4, it has become a 5. That is going towards the serosa, but mostly in the muscle, somewhat in the serosa. Now it becomes a 6. It is very less in the muscle, mostly in the serosa. Type 7, only in the serosa and hanging. Hanging means pedunculated. Something hanging. Look here. See, something hanging with a stalk. Let's say if you imagine this head as a ball. Okay. So this is hanging. This is hanging. Suppose it is hanging like this. This is pedunculated. Something is hanging. You have bulbs hanging with long metal poles, pedunculated. Our fans are hanging with those poles, pedunculated. Okay. Something hanging. So let us see this. So that is the basis of the FIGO classification. So we always start with the type 4. Once you see the type 4, intramuscular. Okay, I'll stand on the side. Okay. Type 4 is intramural here within the muscle. Then it goes towards the cavity. So 100%. See the type 3, it is 100% intramural, but it is touching the cavity. Now, it is more than 50% in the muscle. Look at type 2, please. 50% in the muscle, but partly in the cavity. Now, type 1, less than 50% in the muscle, but rest is in the cavity. So, type 1 is less than 50%. So, type 2 is more than 50%, type 1 is less than 50%. And type 0, pedunculated, intracavity fibroid, hanging. Look, what I want you to consider here is that in all this nomenclature, I have said the intramural part first. I've always mentioned the intramural part first so that you don't have confusion in understanding. So it starts in the muscle and it is going towards the cavity, type 3, partly in the cavity, type 1 more in the cavity, type 2, and totally in partly in the cavity, type 2, more in the cavity, type 1, and totally in the cavity, type 0. So that is the classification. Now you have to see the other way. From 4 it becomes a 5. More than 50% in the muscle, but it is partly in the serosa. See, subserosal, type 5. Type 6, less than 50% in the muscle, but mostly in the serosa. See, 6. I showed you earlier also, now I have written this here. And type 7, subserosal, pedunculated, hanging. Now, these are the basics. Now, there is another type of fibroid which is found only in the cervix. So, that is what is a type 8 or the parasitic fibroid. Also, there is another one. So, type 8 which is in the cervix. A fibroid in the cervix is known as type 8. Okay. But type 8 is also a fibroid which is, let's say, which has detached and is somewhere else in the peritoneal cavity. So there is a fibroid like type 7, it gets detached and now it is sitting in the pouch of Douglas. So we say it is type 8, or it might be detached from there and it might be lodged under the diaphragm. That also becomes a type 8. So cervical fibroid, here any fibroid of the cervix is type 8. Any fibroid of the cervix is type 8. There we don't say muscle mein jyada, muscle mein kam, all that doesn't come there. Any fibroid in the cervix is type 8. And fibroid which is in the pouch, which is away from the uterus, we say it is somewhere else. The fibroid was starting in the uterus, but now it is found in the pouch and it is growing there. It is formed in the diaphragm, it is formed in the omentum. That is what is known as the type 8 also. All right. So type 2-5. Now this came only once in the INICT, so I have to teach you that. Part of the fibroid is partly, see the 2-5. Part of the fibroid is coming into the cavity here, see? Yeah, but part of the fibroid is also coming to the serosa here. So one fibroid has a cavity ka part and the same fibroid also has a serosa ka part. It has got two parts, this fibroid. This part, this side it is coming to the mucosa, that part it is going to the serosa also. That is what is a 2-5 fibroid. It's a hybrid. It has got two connotations. दो जगह से, मतलब एक जगह से वो म्यूकोसा में आ रहा है, दूसरी जगह से सीरोसा में भी जा रहा है. So that is a 2-5 hybrid fibroid. All right. So that is the FIGO classification. Now tell me, what is this fibroid? Yes, I have marked an arrow here and tell me, what is this fibroid? This she's got many other fibroids here. She's got a tube and the ovary. See the altered tube ovary relation. Can you see this altered tube ovary relation here? And that's why infertility in fibroids also. But tell me, what is this fibroid which is having a stalk here and a big fibroid which is small stalk on the surface? Yes, this is a type 7 fibroid, isn't it? That's a type 7 fibroid. And this, when there's a stalk, they can get twisted on their stalks. All right. What is this fibroid? See, I've cut open the uterus to show you the fibroids. This is a fibroid which is mostly in the muscle and it is just touching the cavity. So I'll say it looks like a type 3. And here there's a fibroid here which is mostly in the muscle but partly in the cavity. So this looks like a type 2 fibroid. This here looks more like a type 50-50 type लग रहा है, type 6 लग रहा है मुझे अभी ये. So these are the types of fibroid you can be asked. This is a little borderline kind of case, but yes, they are fibroids. They will give you a section and ask you what type of fibroid it is. या फिर they'll not give you a picture. They'll just draw and ask you what type of fibroid is this. And this is a fibroid inside the cavity. This is a fibroid inside the cavity which is hanging. This is a hysteroscopic view. So can you see a nice round structure which is hanging? This is a pedunculated type 0 fibroid. What is this fibroid, guys? This is my favorite picture, one of the hysterectomy specimens. So you look at this and think that this is the fibroid. Some of you thought that. Don't lie to me. You thought that, isn't it? This is not the fibroid. This is the uterus. ये यहाँ पे tube है. This is the tube. This is the hysterectomy specimen. We've taken out the uterus. And this whole thing here is the fibroid. Look, this is the mouth of the cervix. You're seeing the opening of the cervix here. And the cervix is involved in the fibroid here. So any fibroid in the cervix is type 8. This is a type 8 fibroid. Okay, type 8 fibroid. It's got a very interesting name. Lantern on the dome of St. Paul's Cathedral. St. Paul's Cathedral, लंदन में एक चर्च है. चर्च के ऊपर एक लालटन है. उस लालटन के जैसा ये दिखता है. तो पहले हमें जनरल नॉलेज भी पता करनी पड़ेगी टू अंडरस्टैंड द appearance of this fibroid in the cervix, if you know, you have passed your exam. But it is called the lantern on the dome of St. Paul's Cathedral. All right, that is what is the St. Paul's Cathedral here. ये जो यहाँ पे दिख रहा है ना, lantern on the dome of St. Paul's Cathedral, वो वाली look है ये. Thanks to Google, I have also seen it. Of course, when I finally reached London and saw that, इतना बड़ा चर्च है, उसके ऊपर आपको दिखता भी नहीं है. कैसे उनको पता चला ये lantern is like that? But हम लोग अपने बचपन से, मतलब right from my third year of MBBS, my professor has been, you know, all our professors have been telling about the cervical fibroids, lantern on the dome of St. Paul's Cathedral. All right, so that is a very, you know, traditional gynecologists love to hear these things. Okay, चलो आगे करते हैं ये symptoms की बात. There is pain, abdomen, dysmenorrhea, and compression because of fibroid of vital organs such as the ureter may also cause hydronephrosis. These fibroids can become very big, and torsion can happen. Fibroids can get turned. So this patient here, see the fibroid which I showed you earlier, this actually came to me with a torsion, severe pain abdomen. So we had to do an emergency hysterectomy. She was an older woman, so we could do a hysterectomy. Anyway, there were so many fibroids in this patient. So this, see, this area can undergo a torsion. So that's what is one of the problems, but that is very rare. Huh? Torsion is not the commonest. Don't say torsion is the commonest. No. Pain abdomen, menorrhagia, and you know, dysmenorrhea, these are the major symptoms. All right. So what is the other problem with fibroids? The fibroids can have, apart from pain and increased bleeding, the fibroids can undergo a degeneration. These fibroids can undergo a degeneration. So these tissues, these extra tissues, when they get degenerated, there are multiple types of degeneration. So this becomes a short note in your exams. What are the types of degeneration you see in fibroids? So most common degeneration is the hyaline degeneration, and the rarest degeneration is the sarcomatous degeneration. I try to make you understand the core basics. So commonest is the hyaline, and the rarest is the malignant degeneration or the sarcomatous degeneration, which is, they've asked you less than 1% cases, you see this. All right. Then there is the calcific degeneration. They can be, that is a womb stone, cystic degeneration, fluid type of collection, lipoid degeneration, fatty collection, necrotic or infectious degeneration. But most common is hyaline and rarest is sarcomatous. But there's another degeneration which I have not even mentioned here. That is the red degeneration, and red degeneration seen in the pregnancy. So that's why I have given you another slide for that, a more dedicated part for this red degeneration. So most common in pregnancy is the red degeneration. This is the solid MCQ. Red degeneration seen in pregnancy, and this starts in the second trimester, and it presents with pain abdomen and uterine tenderness and fever. The treatment is conservative. Purple, red due to thrombosis of the veins. All right, more description. Conservative management, that is painkiller de do, say sedation de do, aram kara do. She is pregnant and having a fibroid. So yaad rakho, the biggest problem with fibroid surgery, biggest problem with the fibroid surgery is that a fibroid surgery will bleed a lot, even in a non-pregnant woman. Biggest problem. The chapter now will turn towards that, कि fibroid में bleeding कैसे कम करनी है. That's the only discussion after this introduction. So now the woman is pregnant. In addition to having a fibroid, she is pregnant. She's got this pregnancy. Now when there is pregnancy, along with that there is a fibroid. This is an extremely vascular time, extremely vascular surgery. It will be, I mean, the area will be so vascular that if you make an incision on a pregnant uterus, I don't know, some of you are interns if you're watching this, and those final year students who have seen cesarean sections. Any cesarean bleeds a lot. So that's why we do a lower segment cesarean, and the resident is busy making sure that the lower segment doesn't bleed. If that uterus can bleed so much, suppose you're trying to do a fibroid removal in a pregnant uterus, that can bleed like crazy. So bleeding in fibroids is a major problem, and fibroids bleeding in pregnancy is still bigger. So no surgery, conservative management, painkillers and rest and sedation. So NSAIDs we give her in pregnancy, we give her sedation and we give her rest, but we give no surgery. Okay, no surgery of fibroid in pregnancy. Remember that basic. All right, chalo. Now this is a menorrhagia as the most common symptom. I'm trying to show you what is the cause of bleeding in fibroids. Now this is where they want to ask you a lot of questions. So let me try and show you with this example. Simple example here. Look here. Why do fibroids bleed so much? What is the most common presentation of a fibroid? Excessive bleeding. Don't forget that. Pain bata diya, dysmenorrhea bata diya, degeneration bata diya, and compression of other organs I told you. But overall, the core understanding, fibroids bleed a lot. Menorrhagia is the most common presentation, excessive bleeding. What is the mechanism of excessive bleeding? So normally, when the uterus, okay, there is a fibroid here. I'll show you with a normal uterus here. This is a normal uterus, and in this normal uterus, you're seeing that the lining will shed every month, and the base of the uterine muscle, the glands here, these glands, when they shed, the base of the glands, the blood vessels are going through the muscle of the uterus. Those glands, when they shed, the base of those glands will bleed. That's why when shedding happens, glands will come out and blood also comes out. So lot of women will have bleeding in periods, and that bleeding is 5 days, 3 days, 4 days normal. So to reduce the bleeding, what does the uterus do? All these blood vessels which are bleeding, the uterus undergoes a contraction. Uterus contracts to stop the bleeding. That's a normal mechanism for any woman who is having menstruation. But what happens when there is a fibroid in the uterus? Look, I'm making a uterus with a big fibroid now. Can you see this? There's a uterus with such a big fibroid. So now she sheds the endometrium, she has bleeding little bit, but the uterus is not able to close totally. See, it is not able to contract and close totally. So uterus is contracting, it is trying to close, but the fibroid is acting like a foreign body and not allowing the uterus to totally contract. So uterus wants to contract and stop the bleeding, but the fibroid is in the way. So this is the reason why the uterus cannot contract completely. Ineffective contractions. So contractions stop the bleeding. Remember, in PPH also we say contractions stop the bleeding. In a normal uterus also, uterus closes the blood vessels by contraction. That is not able to happen because of this foreign body. So that is one reason. Number two, the glands of the uterus, they are formed over the lining here, they are formed over the lining here, but they're also formed all over the fibroid, below the fibroid and behind the fibroid. All over the glands will be formed. So number of glands is more in a case of fibroids uterus. All right. So this is what you have to understand. So increased endometrial surface, ineffective contractions, and increased congestion because of increased vasodilator prostaglandins. These three things are the reason why there is more bleeding. Remember these causes, guys. Also, there are other patterns like there is progressive menorrhagia, that is more with the intramural and submucosal fibroids, and menometorrhagia due to submucosal fibroids. These are the patterns. So menorrhagia, progressive menorrhagia, and menometorrhagia. These are the fancy names which are associated, but basically you have to say menorrhagia. If you say that part, you have passed your MBBS exam and you passed your entrance exams. If that you know, I'm happy. These are the other fancy terms. Yes, it is progressive menorrhagia, that the menorrhagia goes on increasing. Next month she'll have more, and the month after she'll have still more bleeding. And menometorrhagia means irregular acyclic bleeding. So because of submucosal fibroids. Infertility because of the altered tube-ovarian relations, which I told you already, but in addition to that, increased uterine contraction will not allow the embryo to implant. That is simple. Associated PID and endometriosis can happen. Distortion of the cavity can happen because of the fibroids, and then blocked tubes, especially at the cornua, and also due to the stretching of the tubes. The tubes which are so badly stretched, I showed you a couple of pictures. The tube which are so badly stretched, those stretched tubes will obviously get blocked, and also because of the compression by the fibroid, the tubes can get blocked. And bowel and bladder symptoms can happen. You see this fibroid at the top. I'm trying to show you a woman like this, like the way I'm standing. I'm trying to show you a woman from the front to the back. So you can see the pubic symphysis. This is the anterior part of the lady, and then this is the bladder, this is the uterus. Now there is a fibroid on the uterus. It is pressing on the bladder, so it will cause her to have more frequency. First there will be hesitancy, then with the fibroid increasing size, there will be more compression on the bladder, there will be more frequency. Then eventually the fibroid becomes very big, there could be retention of urine. Now retention of urine is more because the posterior cervical fibroid. This posterior cervical fibroid, it becomes so big. See this? Look at my hand and look at this cap, which I'm trying to show as a posterior cervical fibroid. So this posterior cervical fibroid will press the uterus forward. See, it will press the uterus forwards. It will press the uterus forwards, and that will compress the compress the urethra, and that compression will cause retention of urine also. So yes, positive fibroids can cause constipation, they can cause retention of urine. So initially there is increased frequency, hesitation, and then they can be urinary retention by the posterior cervical fibroid, like I told you. All right. So diagnosis can be done by ultrasound, but the best diagnosis of the fibroid is done by the MRI, fibroid mapping, where the fibroids are present. That is best done by the MRI. Okay. Before we say that I have to do a myomectomy, I have to take out the fibroid of this lady, make sure that you assess the endometrium also. A lot of times the fibroid might be just present in the body, not doing much, but she may be having an endometrial hyperplasia. That could be the cause of bleeding. So always rule out other causes of bleeding apart from the obvious cause. Rule out the other causes. So rule out an endometrial hyperplasia. So before you do the major surgery of the fibroid, always look into the endometrium, the lining of the uterus. That one biopsy should be taken to make sure there is no hyperplasia or, God forbid, a cancer of the endometrium. Right. So what are the principles of treatment of fibroids? Before I rush into that, because we are revising our understanding of fibroids, but now what are your questions before I go into that? Menorrhagia is more than 80 ml of bleed, and can it cause cancers? Yes, I told you. Yes, Sudha, I told you that it can have a malignant degeneration. Yes, so that is what is a cancer. Malignant degeneration is what is a cancer. Can cause, not so common. Rarest, less than 1%. I told you that, right? Why no surgeries? Pregnancy fibroid? Please repeat. Because a lot of bleeding. Uterus is a very congested uterus, lot of blood in the uterus. So if you do a cesarean also, that muscle bleeds so much during a cesarean. So a fibroid in pregnancy, if you operate, she can bleed to her death. That's why we don't do. All right. Infertility because of the all the parts you want again. I think you can revise by doing a rewind and play. But I can help you quickly. Infertility because of the altering tube ovulation. The tube gets here and the ovulation is here. Right from the beginning of the chapter, I'm telling you, altered tube ovulation, and reduced implantation because the uterus is contracting. It will push the embryo out when the embryo comes for implantation. So that is one thing, altered tube ovulation, then reduced implantation because of the uterus pushing out the embryo, and also because of blocked tubes. It's there. You can revise once more. And bowel and bladder because of the shear compression by the fibroids. Okay. So what are the principles of treatment? What are the mechanisms of treatment? That is methods of treatment. That is, you can do a myomectomy or you can do medical management. All of that we'll discuss. But whom will you treat and whom will you not treat? That is also one question which keeps coming in the exam. This is the only question which came in the INSCT and the MCA exam 1 year. Only question was which will you treat and which you will not treat. What is the treatment? Most of you know. But which one requires a treatment, which one doesn't require treatment? So that's why we have made, this kind of table is not there in any of your theory books, but this is what is accepted, protocols across most of the practicing surgeons, right? More or less, these are the accepted protocols. So if there's a small fibroid and there are no symptoms, there is no pain, no bleeding, and no infertility. Three main symptoms of fibroids. Most common is pain, most common is bleeding, but pain and infertility also are the symptoms. No PBI, no pain, no bleeding, no infertility, no symptoms are there. Because the fibroid is a very small fibroid and it is, let's say, somewhere here. One chota sa subserosal fibroid is there, only 2 centimeters, and it is just like 30% women have fibroids. Not everybody will have symptoms. So it is like a small mole on the face. Sometimes we have a mole on the arm. We don't know anything about it, isn't it? So that is a small fibroid. It is doing nothing. No pain, no bleeding, no infertility, no treatment required. No treatment required. All right. Small means less than 5 centimeters in size. Now, small fibroid less than 5 centimeters, but patient has pain, bleeding, or infertility. One of these symptoms are there. Because the fibroid is here, it is again 2 centimeters only, but it is, let's say, a submucosal fibroid. A fibroid which is in the cavity like this will have more endometrial glands growing, will have a menorrhagia, will also interfere in the contraction, will have menorrhagia, will have a lot of pain also. So pain and bleeding will be there, and this fibroid will also cause infertility. So any of these symptoms will be the reason I'll have to do treatment even for a small fibroid. Treatment is required. Then large fibroid more than 10 centimeters. Suppose the fibroid is as big as 10 centimeters and has pain, bleeding, infertility, obviously treatment will be required. What is the treatment? We'll see. I'll tell you. Depends on the age, family, that is number of children, all that. We are discussing that next. But treatment karna hai ki nahi karna hai? We are just staying there. All right. Then large fibroids more than 10 centimeters, but has no pain, no bleeding, and no infertility. Now this is the MCQ which has come in the exams. Large fibroid which is asymptomatic. Please remember, this is an MCQ. Large fibroid which is asymptomatic. What do you do? Think. It's a large fibroid. She is, let's say, 51 years. She's had menopause. No periods. She's not having menorrhagia. And menopause, there is no chance of her saying, I'm infertile, because she's already in menopause. She already has the children which she wants to have. There is no pain. There is no bleeding. Definitely, there is no infertility. She is 51 years. She came to me for a health checkup. Sir, I am 51 and my family wanted me to come for a health checkup because I got into menopause. So, mera full body checkup kar lo. I do a full body checkup and I do the investigation and all. Well, any doctor can write all those basic health checkup kind of things. And I do a general physical examination. Blood pressure and CVSRS, pulse rate and anemia, breast, thyroid, everything. Then I am doing a per abdominal examination. I see, you have a big tumor in your tummy. I do the ultrasound and see it's a 12 centimeter fibroid she has. Sir, मुझे तो कुछ problem ही नहीं. I don't have any pain, nothing. I don't know that I have a fibroid. Totally asymptomatic. What do you do for that fibroid, guys? Come on, tell me. That was your question. So yes. What do you do? So yes, this is that one question. Large fibroid without any symptoms is still a reason for you to treat it. It is still a reason for you to treat it because it is asymptomatic now, but it is large, and large fibroids can have all those degenerations which I told you. They can have degenerations, they can have a torsion, and they can have also malignant transformation. Malignant degeneration can happen. Like Sutta was asking me, can cancer happen? Although it is rare, but it can happen. So large fibroids cannot be left alone. Treatment is required. Again, treatment is required. So there is only one fibroid where no treatment is required, and that one is the small asymptomatic fibroid. Small with symptoms, large with symptoms, and large without symptoms. All these fibroids, you will do the treatment. All right, guys? So yes, try and understand this. Extremely important. All right? Okay, so now we'll get into what are the methods of treatment. Before that, what are you asking me? More than 80 infertility, please. Okay, all that we discuss. The blood solid small fibroid less than 5, so will it fall off? Can it grow in future? Yes, it depends on the location, future doctor. It depends. If it is in the muscle, if it is a 5 centimeter fibroid, kitna likha tumne? 5 centimeter. If it is a 5 centimeter fibroid here, this will grow. It will become very big. यही तो है. पहले 1 होता है, फिर 5 होता है, फिर 15 भी हो सकता है. But if it is here, who knows? It may just degenerate and it may fall off. Correct. If it is here in the mucosa, she will not quietly go off from the OPD. She'll have a lot of symptoms. So depending on the location, the fibroids may become bigger. Correct. They can become bigger or they can shrink also. If they are subserosal, the blood supply may actually reduce. But if they are subserosal, they can undergo torsion and come with acute emergencies. So fibroid, every fibroid is open. The number of fibroids I've removed in my life, and touch wood, all of them have gone home well, and I keep thanking the Almighty. But every time I open a fibroid, like while I'm teaching you today, yes, 24th of January 2026, next week I have a major fibroid removal in my hospital, and I'm already on the back of mind, I'm thinking, sab kuch theek ho jaye uske saath. And I'm pretty senior now. And even I may try to act very confident, but अंदर से मुझे भी डर अभी भी लगता है. There's a famous ad, no? डर सबको लगता है, अभी भी डर लगता है, because fibroid can bleed like crazy. सबसे बड़ी problem है fibroid में. So we always hope that our experience helps the patient and she has a favorable result at the end of the surgery, and we are able to give her the best results, because a lot of time we have to remove only the fibroid and save the uterus. A lot of time you have to take out a big uterus away because it's a big fibroid. You have to do a hysterectomy. Anytime this fibroid surgery can bleed a lot. So yes, treatment is required, and it is Only one place where treatment is not required, it's a small asymptomatic fibroid. Majaveer Singh, what did you ask me? Oh, can you do this in Pakistan? I'm sure we can do this in Pakistan. Why not? I think you'll have to, I'm sure somebody is reading this. My team is reading this and they will get back to you. Why don't you just send a hi to me? My number is there all over. A lot of your Pakistani friends have my number, man. All of the groups where I am. So you can just send me a message and I'll send it forward. Anyway, I'll ask okay, I'll do that. I'll ask my team to get in touch with you through this. You can just write, okay? So let's move on and see the other things. Principles of treatment, large fibroid, all this I've written, all of that I've written. Large fibroid, if it is asymptomatic, what I told you, it can require treatment. So it is all mentioned here as notes. So let's, yes. So to save time, I wrote some notes for you already. So medical management of fibroids, surgical management and medical management. Medical management aims at reducing the bleeding and reducing the size of the fibroid and also reducing the bleeding during surgery. So reduce pain and bleeding, you can give tranexamic acid. GnRH Enlox is the best medical management. It causes downregulation of the pituitary. Same, I told you in the beginning of the class today. If you start today's Farre chapter, the first thing I said, estrogens are the cause of fibroids and of endometriosis. So basic treatment is reduce the estrogen. That's the first line I said when I started today's chapter. Okay, so we can reduce the congestion of the uterus and the bleeding by GnRH Enlox, again by downregulation of the pituitary. All of that I've given you. So reduce the menstruation, that is the medical management aim. The aim of medical management, reduce the menstrual bleeding, reduce the size of fibroids, reduce congestion and intraoperative bleeding, all right? And tranexamic acid will cause the menstrual bleeding to reduce, okay? So that's what is the. Now, apart from GnRH Enlox, we also have something called the GnRH antagonist. GnRH Enlox work on a principle कि pituitary को इतना stimulate कर दो कि pituitary थक जाए. Go on stimulating the pituitary gets tired and pituitary doesn't work. So pituitary is not working, we have happy results. GnRH antagonists भी हैं. They will directly inhibit the pituitary action by antagonizing the GnRH action. So there's a GnRH antagonist also can be used to suppress the pituitary. Then we can use mifepristone. It's an anti-progestin. It has an anti-growth action. All right, and mifepristone also can be given. Ulipristal estate, selective progesterone receptor modulator. It's a pure antagonist action, and that also is given for fibroid management. I'm just quickly running down the medical management, and we can use Mirena, intrauterine progesterone devices. That IUCD, Mirena. What is basically Mirena? It is progesterone. So what happens? This progesterone in the IUCD, this will act on the endometrium, and you know that high dose progesterone will cause atrophy. High dose progesterone will cause atrophy of the endometrium. So endometrium gets atrophied. Although there's a fibroid here, but the endometrium, this endometrium gets totally atrophied. So yes, fibroid cause increase in bleeding from the endometrium. That endometrium have caused it to become atrophic by the IUCD having progesterones. So you can give progesterones to eat, they can cause atrophy, which I told you earlier in the discussion with endometriosis. Now I'm telling you the same progesterones in the uterus we can give by IUCDs, the impregnated with progesterones, and they can cause atrophy. So I told you atrophy is the new word which I introduced in your lexicon this evening. We have introduced a new word, एक नया word सिखाया था मैंने आपको, atrophy. एंडोमेट्रियम की एट्रोफी करके हमें फाइब्रॉइड्स और एंडोमेट्रियोसिस दोनों में मदद मिलेगी. शुरू में मैंने बता दिया कि फाइब्रॉइड्स एंडोमेट्रियोसिस इज बिकॉज ऑफ हाई ईस्ट्रोजन. दोनों को ट्रीटमेंट कैसे करते हैं? रिड्यूस द ईस्ट्रोजन. दैट्स व्हाई ये दोनों चैप्टर्स हमने साथ में पढ़ाए आपको. ये आपको याद होना चाहिए था. What is the most effective drug? I told you already, the best medical management of fibroid is GnRH Enlox. That's what I showed you in the previous screen. New methods is uterine artery embolization, preferably after 35 years. You can embolize the uterine artery, so the blood supply to this uterus will reduce, and to the blood supply the fibroids will reduce. Medical management you can do. And menorrhagia also will be reduced by this. Then surgical management. So medical management is what I told you. It is to prepare the woman sometimes for the surgical management also. So hysterectomy can be done for the surgical management of a fibroid. Hysterectomy can be done generally when women have completed family. So mostly we keep it for women after 40 years. Women after 40 years generally, and those who have completed their family. All right. Now, younger woman, myomectomy we'll do. So, myomectomy, that is removal only of the fibroid. Removal of fibroid only. That is what is a myomectomy. Now, when we are trying to remove the fibroid, that myomectomy can be an extremely bloody surgery, can bleed a lot. All right. Now, that removal can be done by open surgery, open the abdomen, do it, or can be done by laparoscopy. So, सबके अलग-अलग criteria हैं. Gross criteria I'll tell you. So, laparotomy can be done for all sizes. Laparotomy can be done for all sizes. All fibroids. All sides. पेट काट के तो कोई भी फाइब्रॉइड कहीं पे भी हम निकाल सकते हैं. Laparotomy. All right. Now, laparoscopic is, can you see now? If I put a laparoscope in the abdomen, see the laparoscope will go like this and this is the uterus. When I put a laparoscope like this, or I'll show you on my something like this. See this? This is the uterus. Okay, my hand is the uterus and I'm putting a laparoscope like this. Okay, you can't see the laparoscope. Okay, this is the laparoscope. This pen is the laparoscope. So I put a laparoscope like this, and with the laparoscopy, which fibroid I can take out easily? Obviously, the fibroid which is on the surface will be easily accessible rather than the fibroid which is inside the cavity, isn't it? So, with the laparoscope, I can take out a type 6, type 7, maybe even a type 5, but that requires more skill. So, laparoscopic removal of fibroids, you should try only if you've done a lot of open surgeries. I have repeatedly said in this topic, the only problem I'm worried about in fibroid is the bleeding during surgery. तो प्रेगनेंसी में तो सर्जरी करनी नहीं है. ग्रॉस प्रिंसिपल बता दिया. अब आपका प्रोफेसर बोलेगा यार मैं तो कर सकता हूं. योर प्रोफेसर इज अ गुड प्रोफेसर. रेयरली extremely smart surgeons can do. I'm not discussing here that how many fibroids are removed during the fibroids during the pregnancy. This is not the forum. Fibroid in pregnancy don't touch. एक basic principle है. हमें core basics पढ़ना है. Exceptions in post graduation will teach. Okay. So fibroid in pregnancy don't touch. Fibroids can bleed a lot, and when fibroids bleed a lot, you have to be smart in the surgery. So laparotomy, any tumor, any fibroid, any size we can take out. Laparoscopy, it's better that we take out for type 7 and type 6, maybe type 5, but I'm not writing. Now hysteroscopic, go into the uterus. See, I'm going into the uterus with a hysteroscope. Which one I can take out? Hysteroscopically with a scope inside. So I can take out a type 0, I can take out a type 1, maybe a type 2, but again surgical skill has to be better. So hysteroscopic for type 0, type 1. These are the outright core basics. And before doing a myomectomy, you should have some understanding that the hemoglobin should be built up. So you can make the woman amenorrheic. Uska periods band kar do, GnRS de do. Stop her periods so that she regains her hemoglobin. Give her iron ferrous sulfate capsules. You may give her blood transfusion, but if you can stop the bleeding and plan the surgery, that's always better. So many times we stop the periods of the lady, build a hemoglobin up, and then only do the surgery, because if the hemoglobin is less than 10, then the healing of the tissue is also going to be difficult after the surgery. So HP should be more than 10. Rule out other cause of infertility. Who knows, if you're doing a myomectomy, the cause of myomectomy could be that the man is having azoospermia. आपको लगता है कि एक बड़ा सा फाइब्रॉइड था 6 सेंटीमीटर्स का, and that fibroid is the cause of infertility. You're planning a myomectomy. But actually the fibroid was a subserosal fibroid and it was somewhere here, let's say 6 centimeters, and the tubes are away from this fibroid and the cavity is away from the fibroid. So this, even if it is 6-7 centimeters, it is not troubling the tubes, it is not troubling the cavity. आपने उसकी सर्जरी कर दी. So myomectomy कर दी, it's a bloody surgery, it's a risky surgery. I've been scaring you about the myomectomy. फाइब्रॉइड निकालने में ब्लीडिंग हो जाता है. बट द पेशेंट कम्स टू मी आफ्टर 1 year एंड सेज, सर मेरा तो प्रेगनेंसी हुआ ही नहीं, आपने तो सर्जरी कर दी, आई एम नॉट प्रेग्नेंट स्टिल. एंड देन यू फाइंड आउट विद द सीमेन एनालिसिस ऑफ द हस्बैंड दैट ही इज एजोस्पर्मिक. ही इज एजोस्पर्मिक. अरे यार ये तो बड़ी मुसीबत हो गई. व्हाई डिड यू डू अ सर्जरी फॉर दिस लेडी व्हेन द मैन इज एजोस्पर्मिक? दिस इज अ प्रीरिक्विजिट दैट hemoglobin should be more than 10, and you should have done a semen analysis of the husband before doing a myomectomy, because that myomectomy was a dangerous surgery and the woman could have died in the surgery. Yes, this has happened. Many doctors, it has happened that patients have lost their lives during a myomectomy. So please do this major surgery only if the semen analysis is fine. Okay, then during the surgery, minimal fimbrial and tubal handling, नहीं तो adhesions बढ़ जाते हैं. Minimal incisions on the uterus, and avoid posterior wall incisions because it can cause fixed retroversion, which causes infertility. This we've discussed in the chapter of infertility in our app also, and fixed retroversion can be a problem. The retroversion uterus, I can explain you again like this. So when the woman is having intercourse, the sperms are deposited. Suppose this pen is the penis and the sperms are deposited in the posterior wall of the vagina. The cervix is downwards and forwards like this. So cervix is picking up the sperms after intercourse, but that is when the uterus is straight like this, anteverted, straight like this. But if the uterus gets retroverted, if it gets retroverted, the cervix will miss the pool of semen, and that's why the patient will not get pregnant after intercourse, because of a fixed retroversion. So that fixed retroversion can happen more if you do a posterior wall incision. If you do a posterior wall incision for the fibroids, it causes fixed retroversion. थोड़ा सा PG वाला हो गया ये वाला segment, but never mind, since I have to teach you to become the best postgraduates, you can learn a little bit more, right? चलो आगे बढ़ते हैं. And avoid opening the cavity. You know, sometimes we do end up opening the cavity, but cavity injuries can cause fibrosis of the cavity and more problems in pregnancy later. Now, techniques of reducing blood loss during the myomectomy, we have this myoma clamp. This myoma clamp, if you see this tip, these two prongs which are here like this, these, can you see aisa hai na? These myoma prongs, they are like this myomectomy clamps. So kya hota hai, there's a big fibroid here. So we open the abdomen and put this clamp next to the uterus like this. ऐसे clamp लगा देते हैं. So when you put this clamp, the uterine artery is compressed on both the sides. When I'm operating on this, the bleeding will be much lesser. And then, very important, vasopressin injections. So all of that is coming now. The methods to reduce bleeding. ये सब आएगा exam में. Yes, viva में आएगा. They'll give you a specimen in the evening viva with the fibroid in front of you, and they'll say how to reduce bleeding during surgery. Steps of reducing bleeding during surgery. So myoma clamp, and that is during surgery. But before the surgery, you can give GnRH therapy to reduce the congestion and time the surgery in post menstrual phase of the menstrual cycle. Suppose she had periods on 1st of February and she finishes periods on 4th of February, for example. I'll try to do the surgery between 6th to 16th of February. That's the time, because after ovulation, then the congestion of the uterus increases and bleeding during surgery will increase. So generally post-menstrual rather than pre-menstrual. Okay, arrange blood and FFP. You must always do intrauterine use of a uterine clamp, this myomectomy clamp. Tourniquet, instead of a clamp, we can put a a plastic tube around the uterine arteries. We can do that also. And vasopressin, local vasospasm, you can cause by vasopressin. This is not enough, writing this. I'll show you how we give it. That's what is very important, vasopressin injection. So yes, look here. This is a patient. Wait, I'll have to. Yes, look at this one. I've taken the uterus out of the abdomen, and can you see the size of the uterus is so big? Now I'm injecting vasopressin. Look at this picture and look at this one. Can you see? When you inject the vasopressin, before that it was also red and congested and it was going to bleed a lot. After injecting the vasopressin, can you see it's become all blanched and white? So this is how you're putting the vasopressin here. Always withdraw when you're injecting any drug into any place. Always withdraw any part where you're giving an injection. Always withdraw. If you give vasopressin into the circulation, sudden hypertension can happen. So when you're injecting this vasopressin, we tell the anesthetist, injecting vasopressin. Anesthetists कई बार busy होते हैं phone pay, because anesthesia life. They are very busy in the OT, but they are also having the time to go and have tea in between and catch up on the gossip with their friends. I envy the anesthetist sometimes. All right. वो मेरे को जवाब देते तो नहीं लेना था ना गायनी, क्यों कर रहा है सर्जरी, एनेस्थीसिया करना था. Okay, that war we will discuss when you come to PG life. We'll discuss all that, all the war which goes on between anesthetists and the surgeons. तो ये देखिए, ये this is got totally blanched. देख रहे हो, you give the vasopressin, ये पूरा area देखो white हो गया. Now moment I make incision, hardly any blood loss is there. This is not much, please don't get scared. When you make an incision on the uterus, फुहारे छूटते हैं कई बार. You will have spurts going up till the ceiling of the OT and will come into your eyes so many times. So see, I'm able to do the surgery aram se without any massive blood loss. One, I've given the vasopressin and I put a tourniquet around the uterus, uterine arteries. And then I've given her GnRH analogs before, for 3 months before she came for the surgery. all to make sure that I will take out the fibroid and not take out the uterus when I want to do a myomectomy. So that's what, these are the steps. Chalo. Now this same surgery is still continuing. Then can you see now? This is a big fibroid, you know, it's almost like this with this head of the baby, you know, like this. I've tried to, you know, yes, see here, I've tried to open the uterus like this. Like this, I'm opening up the uterus and taking out the fibroid here. Yeah. See this one now. Wait. Yeah, see this? Now, what is this instrument? I wanted to show you this instrument. This is your instrument. Yes, instrument question. All you exam going students for final MBBS and the PG students, entrance students. This Myma screw. This is what is screwed. This is like a corkscrew. That wine opener होता है ना corkscrew. बिल्कुल उसके जैसा होता है ये Myma screw. It is put into the uterus and gives us traction while I'm trying to do the myomectomy. See, I'm giving a traction to the fibroid because of this. And then we're about to just finish this here. The base, now this is where, this is the part, the base of the fibroid when I'm finally trying to take it out. That base of the fibroid, uske niche hi to cavity hoti hai uterus ki. That cavity should not be injured. Try to, I mean, if you injure the cavity, of course, you will repair it also. It happens. I have opened the cavity many times. It's not that, you know, we have always doing only good things. Yes, we end up in a few complications. But yes, again, touch wood, all the patients go fine and they have good results. Then any surgeon will have complications, but you should know how to diagnose and treat the complications. That's what makes you a good surgeon. Complication होता ही नहीं है, ऐसा कोई surgeon नहीं दुनिया में, कोई surgeon नहीं. All right, चलो, let's move on and see. This is the base of the fibroid which I've taken out, and now you have to close this in layers. And the surface, we say baseball switches on the surface of the spirosa. Right, so this is the number of fibroids I took out. This is just for the size. See, this is more than 10 centimeters. This one big fibroid is around 12 centimeters. So many fibroids in this patient. After the surgery, we generally like to, you know, take a picture, show off. होता है ये, सब लोग थोड़ा पिक्चर लेते हैं ऐसा मेजर सर्जरी के बाद. This is a myoma screw. This is a histoscopic myomectomy. Yes, I was trying to show you कि histoscopic myomectomy करते हैं. तो histoscopic myomectomy also you should be, you know, we use some media to distend the uterus. I'll not go into much detail about this surgery now, but this can also bleed a lot. So you should have done a lot of open surgery before you do laparoscopic myomectomy and histoscopic myomectomy. So this is the histoscopic myomectomy. This is a type 1 fibroid. I told you ना, type 1 fibroid होता है. इसमें it is mostly in the cavity, but some part is in the muscle. More than 50%, less than 50% in the muscle, and mostly in the cavity. So this type 1, I'm going the base of the fibroid to remove this. There's a bipolar cautery which I have. So with that, we try to take out the, yes, we remove this. And then this fibroid has to be taken out. This is almost 3 centimeters, this fibroid. So to take it out from the uterus, that is also another task. Okay, remove तो हो जाता है, but how do you take it out? That is also one nuisance. So this is that fibroid. Can you see? ये fibroid ऐसे घूमता रहता है. It keeps running. Can you see? ये internal os है और उस पे fibroid यहाँ पे आके फंस जाता है. So then, can you see that? Yes. Then you have to take it out also. But yeah, once you become a gynecologist, then we'll teach you all these small intricate details. Thank you guys. A lot of things we discussed, much more than what I was hoping that we will do today. But it's always interesting to take a class, and I'm happy that we do all of this. Now, what is Sudha asking me? Why laparoscopy done in time? I'm saying laparoscopy is done for anybody. Yaar. See, if somebody has a gallstone, don't you do a cholecystectomy with an open procedure? But we can do laparoscopic also, so that there is lesser incision, lesser size of incision, and laparoscopy, the patient will recover very fast. Isn't it? Laparoscopy karke patient recovers very fast. Today you do the surgery, tomorrow the person goes home. But you cut the abdomen and do the cholecystectomy, he has to be admitted. Similarly, when you do a myomectomy, open myomectomy, the patient will be in the hospital for 1 week. But you do a laparoscopic myomectomy, she goes home. So laparoscopy surgery is a smarter surgery, more cosmetic. Okay, smarter surgery, and the patient recovery time is much lesser. Yes, pros and cons hain, but much lesser. So why do laparoscopy for 6 and 7? Easy to do. That's why 6 and 7. 4 and 5, they'll be difficult to do. Yeah, what is the possible getting pregnant at age 46? What is it possible? Is it possible at 46 years? Yes, it is possible. But 46 years, we already menstrual physiology chapter, my friend John Batula. You must see the menstrual physiology chapter, and we have already done that. That menstrual physiology, I've taught you that the woman has the best fertility in the first uh, 20 to 25 years of life. Then 25 to 35, it is still good. 35 to 40, much compromise. And after 40, it's only good luck. So after 45, you're asking about a 46-year-old woman. After 45, she cannot get pregnant. I mean, 99%. Yes, a lot of women have conceived spontaneously at 48, 49 years also. That has been shown. Even my own grandmother, she had a last child when she was 49. So yes, it does happen. One of my aunts is only around 4 years older than me. So yes, it does happen. But you must understand that those rarities. Common kya hai? Till 35 to 40, although compromised, that they can be pregnancy. After 40, chance is very less because the number of eggs is less. So after 45, like 46, you are saying, this lady needs eggs from a donor, sperms from the husband, and we can make a baby, and that baby can be put into the uterus. So donor eggs and sperm of the husband can be used to make this lady have a child. Can be done. She can get pregnant, but not with her own eggs. How to find answers? Know how to find answers. Okay, hysterectomy, mammectomy, please. Hysteroscopic. Yeah, hysteroscopic mammectomy. Yes. Yes, you want to see, Sudha? You can see. Hysteroscopic mammectomy with the hysteroscope, you go inside. Ab kya hota hai na? When you go into the uterus, see, this is the hysteroscope, Sudha. You go inside like this, you cannot see anything. You have to distend the uterus. Hysteroscopy की class में पढ़ाएंगे आपको, ठीक है? You have to distend the uterus. Then only you can see. So while you're doing this, all this water can you see bubbling because along with the light, there's a lot of fluid going to distend the uterus. And then with my hysteroscope, you can see through the hysteroscope, this instrument is gone. So I'm seeing with the scope. The scope is somewhere here. This instrument is going through the scope to do the surgery. This is a hysteroscopic mammectomy. Very interesting. Yes, it is very interesting.